Boa tarde a todos e bem-vindos à primeira sessão da 15ª VaP-APIC. Antes de mais, um agradecimento pelo amável convite e felicitar a Comissão Organizadora pela excelência deste programa. Estou certo que será uma fantástica reunião. Eu tenho o enorme prazer de moderar esta sessão com a doutora Marisa Trabulo, com quem tenho o prazer também de trabalhar no Hospital de Santa Cruz. E nós vamos dividir esta sessão em duas componentes. Temos primeiro um live in a box e depois teremos um curto momento de discussão que vamos convidar o nosso ilustre painel a colocar questões difíceis, complexas, e depois vamos ter 3 apresentações e voltamos então no final dessas 3 apresentações a ter novamente um novo momento de discussão. E, portanto, sem mais demoras, eu passo a palavra à doutora Marisa, que apresentará o primeiro bloco.
Boa tarde a todos. Vamos então começar esta sessão com a apresentação de um caso do Hospital de Gaia, um Life in the Box, que vai ser introduzido pelo Dr. Luís Fuga.
Boa tarde a todos. Agradecer o convite à organização, o convite por este desafio do Live in the Box. Estou aqui em nome da equipa de Gaia, o Dr. Bruno Mélica e o Dr. Gustavo Pires de Moraes, não puderam estar e, portanto, à falta de melhor, enviaram-me a mim e, portanto, as perguntas difíceis vamos dar o melhor para responder. Sem mais demoras, acho que podemos passar à apresentação do caso. Obrigado.
Bom dia a todos e bem-vindos ao Serviço de Cardiologia da Unidade Local de Saúde de Gaia Espinho. Quero agradecer à Comissão Organizadora do VaP-APIC 2026 pelo convite a participar com este caso. É um prazer poder contribuir ao programa do Congresso com um pouco da nossa prática. Estou aqui com o Dr. Gustavo Pires de Moraes. O caso que vamos fazer hoje é um caso de reparação tricúspide percutânea. Isto é uma área da nossa atividade que tem crescido de forma muito significativa nos últimos anos, com o acumular-se de evidência e o aparecimento de múltiplas opções de tratamento transcatéter para os nossos doentes. E ao longo dos anos, a reparação percutânea por aproximação de folhetos tem-se mantido como o nosso tratamento mais frequente. Mas a verdade é que tem mudado muito a nossa prática. Gustavo, quem é hoje em dia, em 2026, o candidato ideal para esta técnica?
No fundo, estamos a falar de doentes que tenham alto risco cirúrgico, o risco cirúrgico considerado proibitivo, que tenham uma insuficiência tricúspide considerada grave e que, pelo clínico, seja considerado essa a causa dos sintomas que tem e que esteja sob aquilo que genericamente nós chamamos de terapêutica farmacológica máxima otimizada. Idealmente são doentes que não têm grande disfunção do ventrículo direito e que não têm pressões pulmonares consideradas muito elevadas. Tipicamente, falando sobre este procedimento de aproximação de folhetos, o doente ideal será aquele que não tenha um gap de coaptação muito grande, estamos a falar de gaps de coaptação idealmente inferiores a 6 mm, anéis que não sejam muito grandes, e que tenham jatos que sejam fundamentalmente centrais ou então que envolvam a comissura entre o folheto anterior e o folheto septal. Doentes nestas categorias, que não tenham grande repuxamento dos folhetos, que não tenham grande densidade de cordas, são aqueles que idealmente são favoráveis a uma aproximação de folhetos. Aqui na sala temos connosco também, além do Dr. Bruno Mélica, que é o coordenador da equipa e que vai ser o operador principal neste caso, temos na imagem o Dr. Luís Fuga, temos na anestesia a doutora Ana Fontepoa e temos connosco também a enfermeira Teresa Silva, temos a enfermeira Olivia Cunha e temos também connosco a enfermeira Estela Miranda. Portanto, sejam bem-vindos, juntem-se a nós para este caso.
Muito obrigado, Gustavo. Vamos passar a palavra à doutora Marta Almeida, que vai apresentar o caso, o doente que vamos tratar hoje.
Bom dia, venho então apresentar o caso clínico que vamos intervencionar hoje. Uma senhora de 78 anos, autónoma, com antecedentes de hipertensão arterial e diabetes mellitus tipo 2, que é referenciada à nossa consulta de cardiologia por uma insuficiência cardíaca com fração de ejeção preservada, mas com uma insuficiência tricúspide grave descrita em ecocardiograma do exterior. Apresenta ainda como comorbilidades uma fibrilação auricular permanente, uma doença renal crónica estadio 2-3 e uma anemia ligeira. Na nossa primeira avaliação, em julho de 2025, A doente reportava dispneia em agravamento progressivo nos 2 meses anteriores, estando em classe NIA 3 a nossa avaliação. E tinha também percepção de edema periférico e de aumento do perímetro abdominal. Ao exame objetivo, efetivamente constatamos turscência venosa jugular, crepitações bibasais e edema dos membros inferiores bilaterais, e a doente tinha ainda uma auscultação cardíaca arrítmica com um sopro sistólico grau 3 em 6, essencialmente mesocárdico e apical. Neste momento a doente já estava hipocoagulada e já estava sob 120 mg de furosemida e decidimos então iniciar metolazona 5 mg 3 vezes dia para tentar ajudar à descongestão. E a doente mantinha a sua terapêutica antihipertensora e diabética, que já incluía um inibidor de SGLT2. Apesar da doente ter melhorado alguma coisa do ponto de vista da avaliação objetiva de congestão central e periférica, ainda se mantinha em classe NIA 3 na nossa reavaliação em novembro de 2025. Para esta consulta tinha também feito alguns exames, nomeadamente um estudo analítico que mostrava os parâmetros estáveis quer de anemia, quer de função renal e sem congestão hepática, e fez então a avaliação com um ecocardiograma transesofágico e com o cateterismo esquerdo-direito. No ecocardiograma transesofágico podemos então verificar que havia uma dilatação ligeira do anel tricúspide. A doente apresentava ainda uma insuficiência tricúspide, então, severa a massiva, quantificada, com um jato essencialmente central, dirigido anteroceptal e posteroceptal, e podemos confirmar com um airway de 78 mm² e um volume regurgitante bastante elevado também, com reversão do fluxo nas veias pulmonares. A anatomia parecia ser uma anatomia do tipo 1 e era um mecanismo funcional auricular. A função biventricular estava conservada e tinha dilatação das 2 aurículas. O cateterismo esquerdo-direito mostrou que a doente não tinha doença coronária e tinha já uma hipertensão pulmonar moderada a grave, com pressão média na artéria pulmonar de 37, uma pressão de encravamento de 21 e uma resistência vascular pulmonar de 3,9. Avaliando então os scores aqui de risco, percebemos que a doente tinha algum risco cirúrgico e com um baixo risco para intervenção percutânea com uma anatomia que parecia adequada, e foi então neste momento proposta para implantação de TIR tricúspide.
O dispositivo que escolhemos hoje para este caso é o triclip G5, a última iteração do triclip, que foi lançada recentemente, que traz significativas melhorias da ergonomia e da manipulação do dispositivo, que achamos que vão traduzir numa melhor precisão do procedimento. As novidades têm a ver, em primeiro lugar, com a estrutura de suporte, que mudou radicalmente, particularmente aqui na parte da frente, onde desapareceu o parafuso que fixa o catéter guia e há agora este sistema de encaixe que permite uma forma muito simples e muito rápida de estabilizar o catéter guia na introdução e também rodar no sentido septal lateral, portanto horário anti-horário, de uma forma simples, sem estarmos sempre a preocupar-nos com a posição do parafuso. Também houve alterações significativas naquilo que é hoje o teu departamento, Gustavo, a parte do Clip Delivery System. Queres descrever o que é de novo nesta parte do dispositivo?
Uma das coisas que nos agrada e que também está relacionado com o que o Bruno já tinha mencionado, que é o novo sistema de suporte a este encaixe do sistema de entrega do clip, que fica bem mais estável. O desaparecimento do parafuso também aqui é uma vantagem que nós vemos como estratégica, sobretudo aqui mais acima, em que nós passamos a ter este rotor que permite desapertar e apertar de forma a podermos manipular de forma muito fácil o sistema de entrega do clipe propriamente dito. A gestão das grippers é mais ou menos semelhante àquilo que já existia, fica um bocadinho mais facilitada, mas é parecido com o sistema anterior. Mas, se calhar, o grande salto também relacionado com o sistema de entrega do clipe está deste lado, em que nós passamos a ter uma alavanca de controlo da travagem e destravagem do clipe que é muito mais facilitada. Neste momento é tudo muito fácil, é só rodar para um lado e rodar para o outro, conforme podem ver aqui pelas indicações, para travar e destravar o clipe. E no final também vão ter a oportunidade de ver, isto simplifica muito mais todas as manobras de libertação do clipe.
Para este caso específico, como sabem, há 4 dimensões de clipe disponíveis. Como acontece quase sempre, diria eu, no espaço tricúspide, escolhemos o triclip XTW, que é o maior em termos de comprimento, de largura e que normalmente nos garante os melhores resultados neste contexto. Vamos agora passar a bola ao Dr. Luís Puga, o nosso cardiografista, que vai fazer uma descrição da anatomia desta doente e vamos definir depois um plano, uma estratégia de tratamento especificamente para este caso. Luís.
Olá a todos. Então já fizemos um screening geral do que fazemos habitualmente nestes casos. Em relação à válvula tricúspide, o doente está sob anestesia geral e temos então um jato regurgitante ligeiramente menor, ainda assim mantendo critérios de severidade. Temos uma janela esofágica adequada, podemos ver que os folhetos têm boa qualidade, não estão calcificados nem espessados, não há uma restrição significativa do folheto septal e o jato é predominantemente central. Temos uma dilatação ligeira do anel tricúspide, uma vena contrata biplano cerca de 7 mm, um aeroa de 34 mm², com volume regurgitante de 33 ml, e temos então uma excelente janela transgástrica que nos permite apreciar a anatomia e permite-nos perceber que o gap é sobretudo central e não é proibitivo, será cerca de 3-4 mm.
Qual é que será a estratégia neste doente? Podemos ver, se calhar, Luís, uma transgástrica eixo curto, que nos mostra a válvula en face. Neste caso, o nosso plano é colocar um primeiro dispositivo, um triclip XTW, em posição anterior, entre o feito septal e o folheto anterior, avaliar o resultado e provavelmente depois teremos necessidade de colocar um segundo dispositivo, provavelmente do mesmo tamanho, em posição mais central, entre o feito septal e o folheto posterior. Este é o nosso plano. Vamos começar e vamos ver como é a resposta da válvula à nossa reparação. Acho que agora estamos numa posição correta para começarmos a avaliar a perpendicularidade. O segredo de todos os procedimentos edge-to-edge, e a tricúspide não é exceção, é a perpendicularidade em termos de trajetória relativamente ao plano valvular, e algo que vamos avaliar nesta projeção, o X-plano, do inflow-outflow e do grasping plane, onde podemos ver o folheto septal e o folheto anterior ou posterior, dependendo da posição. Luís, pode ilustrar esta que é uma das mais importantes projeções que usamos neste procedimento?
Sim, portanto, esta é a projeção standard para nós fazermos a orientação da posição e da trajetória e também do grasping. Na imagem da esquerda, nós vemos no centro a válvula aórtica e a válvula aórtica dá-nos uma posição anterior. Portanto, na imagem da esquerda do lado direito temos anterior, na imagem da esquerda do lado esquerdo temos posterior e na imagem da direita temos septal do lado esquerdo e lateral do lado direito, que se tivermos a cortar mais próximo da válvula aórtica, iremos ver o folheto anterior, e se estivermos a cortar mais afastado da válvula aórtica, estaremos a ver o posterior. Em termos de posição, parece que estamos bastante centrais.
Exatamente. Mas agora o nosso objetivo nesta fase é avaliar se a trajetória é adequada no plano anteroposterior, portanto na imagem à nossa esquerda, e no plano septolateral, ou seja, na imagem à direita. Para fazer isso, fazemos pequenas progressões do dispositivo desta forma, para avaliar qual é o comportamento do clipe. Eu estou bastante satisfeito em termos de trajetória. Podemos passar a outra projeção muito importante, que é o transgástrico eixo curto, que nos permite alinhar o dispositivo de uma forma perpendicular à linha de cooptação no ponto da válvula que pretendemos abordar.
Este é o plano transgástrico, podemos ver os músculos papilares. Temos que fazer um corte ligeiramente superior ao plano da válvula para aparecer o dispositivo, que está a aparecer na imagem.
Eu vou aproximar um bocadinho, parece mais ou menos isso, não é?
Isso. Gosto mais assim. Gosto mais assim.
Um pouco
mais horário.
Lateral, talvez. Ok, se calhar vamos entrar, depois otimizamos dentro do ventrículo, ok?
Ok.
Ok. Estamos dentro. Podemos passar para o transgástrico, exatamente.
Acho que estamos com boa posição e com boa orientação também.
Ok, vamos tentar fazer um grasp nesta posição. Okay,
talvez os dois dentro.
Baixei as grippers.
Ok. Vamos fechar.
Deixa-me fechar com cor. Podes?
Estou a fechar, só um bocadinho. Clip lock.
Ok.
Ok.
Muito bem. Ok. Luís, podes ilustrar o que é que procura nesta fase para avaliar qualidade do grasping.
Nesta fase, o que procuramos é ver o bordo, a margem do folheto, com menos mobilidade e a entrar junto à parte mais ecogénica, que é o nosso dispositivo. Eu vejo isso aqui no bordo do folheto anterior, por aqui, a entrar no centro do dispositivo, e parece-me que o septal nesta zona também se vê. Vejo claramente aqui tecido a ser repuxado e vejo menos mobilidade da abertura do folheto nesta zona.
Se calhar possa valer a pena tentar fazer uma otimização antes de libertar o dispositivo. É uma das características que tem o triclip, e acho que nesta fase podia ser útil para uma otimização da captura do folheto septal. Vamos abrir o clipe, mantendo as gripas por baixo.
Querem manter este plano
podemos
isofágico?
manter este plano, sim, sim.
Vou abrir.
Bem. Ok, força.
Queres-me só favor, Bruno?
Claro. Ok.
Ok.
Ok, nesta fase eu vou dar uma rotação septal, obviamente. O septal é o folheto que queremos capturar melhor. O Gustavo vai agora levantar a gripe septal, que foi identificada no início do procedimento.
Era aqui não tinha a marca.
Uhum.
Certo? Levanta.
Exatamente.
Vê se o folheto a entrar.
Vamos tentar subir mais um pouco para o valvular. Voltas, por favor, a baixar. Ok. E agora voltamos ao meio da válvula, a posição neutra. Vamos fechar.
Estou a fechar. Está fechado.
Ok. O que é que temos agora?
Continuo a ver uma boa tensão na captura do septal, que está aqui bastante imóvel. Parece-me até eventualmente estar mais tecido dentro. O espaço desde o dispositivo até à base do folheto talvez seja menor agora nesta fase. Em termos do jato residual ou remanescente, parece-me sensivelmente semelhante.
Portanto, temos um bom grasping, uma boa orientação, uma boa redução do jato regurgitante. Não temos grande significativo a nível da válvula, portanto, vamos avançar para a libertação deste primeiro clipe.
Pronto, só garantir que o clipe efetivamente está fechado, não está a abrir. Esta é uma das novas características do G5, esta alavanca para controlar a abertura e encerramento do sistema de lock and clip. Ele está na posição fechada. Portanto, na primeira fase vamos puxar esta patilha para cima. Depois vamos puxar esta nova alavanca para trás e vamos puxar isto aqui. Neste momento temos uma linha única para puxar.
Olivia.
Porque eventualmente aumentamos um bocadinho o débito do nosso sistema de flush. Nesta fase vamos deixar o sistema numa posição neutra. Okay. E agora temos esta alavanca de segurança. Vamos puxar para trás, vamos retirar esta patilha e depois vamos rodar
Até o stop, não é? Que esta é a grande vantagem. Antes tínhamos de controlar a posição do maranhor, agora, enquanto rodamos até parar, e estamos certos que...
Estamos aqui em cima com a tal ranhura.
Exatamente.
E esta que aqui está. E nesta fase temos 8 rotações anti-horárias a fazer até à libertação do clipe. Certo? Ok. E o dispositivo está certo.
Pareceu-me haver estabilidade do dispositivo na libertação. Parece-me que continua evidente uma boa captura do septal e do anterior. Continuamos com o jato remanescente em posição central, que poderemos abordar com um segundo dispositivo.
Ok, portanto, conforme o plano inicial, colocamos um primeiro dispositivo em posição septal anterior, bem orientado, com um grasping confortável. uma redução do jato nesta vertente da válvula e vamos agora avançar para a otimização do resultado com a implantação do segundo dispositivo, que será novamente um XTW em uma posição mais central entre o fluido septal e posterior. Na posição do segundo dispositivo temos sempre a referência fluoroscópica do primeiro, que me ajuda naturalmente. Nesta projeção direita cranial, queremos pôr o segundo dispositivo paralelo mais ou menos ao primeiro, numa posição mais baixa comparado com a posição do anterior. Portanto, acho que para já não vamos alterar a nossa trajetória, podemos abrir o dispositivo como fizemos há pouco.
Podes deixar esta posição, Luís. Vou aproveitar e vou ver novamente as grippers. Ok. Portanto, que tem a marca que está em posição septal.
Septal, perfeito, muito bem. Portanto, trajetória bem, identificamos as grippers, passamos agora ao transgástrico para otimizar o clocking. Eu acho que podemos dar alguma rotação horária, mantendo o clipe na posição central. Portanto, eu se calhar seria tentado de avançar com o clipe nesta posição. Então vamos entrar. Okay. Trajetória boa, bem paralela ao primeiro dispositivo. Pronto, eu acho que estamos já por baixo do plano valvular. Ok. Mas está, acho que podemos abrir e ver.
Transgástrico outra vez, não é?
Sim. Ora bem, ponto da situação. Estamos no ventrículo, a posição do dispositivo é meio caminho, não é? Entre uma posição paralela ao primeiro e uma posição 9.3. Pronto, eu acho que podemos fazer uma tentativa de grasp nesta posição e ver qual é a resposta da válvula e eventualmente mudar de plano caso não seja satisfatório. Acho que está apoiado, o posterior, podemos baixar.
Também parece.
Ok. Agora vamos tentar apanhar o septal. Eu avancei um pouco para o ventrículo. Vou dar agora um pouco de orientação para septo. Acho que estamos por baixo do septal, está um pouco dobrado. Não é?
Sim, ele está mais restrito nesta zona da válvula.
Parece-me dentro.
Agora para dentro.
Bem.
Baixei.
Vamos voltar ao centro, ok? Podes fechar.
Ok, vou começar a fechar. Com Doppler. Clip lock. Vamos fechar. O clipe neste momento está fechado.
Ok.
E temos tensão aliviada.
Parece-me bem. Jato residual, jato remanescente praticamente nulo. Bom grasping. Gradiente aceitável. Boa posição, boa orientação.
Muito bem. Então, vamos libertar.
Vamos lá então. Vamos a isto, Bruno?
Força.
Vamos lá.
Muito bem. Libertação controlada. Dispositivo estável. Luís, podes escrever o resultado depois deste segundo dispositivo, por favor?
O resultado parece-me fantástico. A libertação permitiu ver que não houve qualquer alteração à posição e orientação do dispositivo. Mantemos com um jato regurgitante, eu diria mínimo, talvez aqui um jato entre mínimo e ligeiro, entre os dois dispositivos. O gradiente continua em 2. Vemos muita tensão sobre os folhetos, de facto um efeito de anuloplastia, já parece o anel efetivamente mais pequeno. Falta só confirmar a posição do transgástrico, mas estou muito satisfeito com o resultado. Parabéns.
Muito bem, portanto, obtivemos um excelente resultado para o segundo clipe. Vamos então considerar terminado a preparação da tricúspide.
Muito bem, Bruno. Vamos então fazer um wrap-up do nosso caso de hoje. Algumas mensagens importantes. Ponto 1. Seleção doente é fundamental. Tínhamos aqui imagem adequada, tínhamos anatomia muito favorável. Segundo, utilizamos as várias características que este dispositivo oferece para orientar o dispositivo de forma gradual até à captura adequada dos folhetos. Acabamos por utilizar o grasping independente sem distorção do folheto e obtivemos aquilo que pretendíamos, que no fundo é redução efetiva do jato e também um efeito de anuloplastia. Finalmente, um dos componentes muito importantes deste dispositivo é efetivamente a segurança, e nós fizemos isto de forma muito tranquila para atingir o nosso objetivo, com o goal último da doente ter alta amanhã para casa, com a manutenção da terapêutica, para conseguirmos remodeling adequado das cavidades direitas. Muito obrigado a todos. Bruno, parabéns pelo ótimo trabalho, parabéns a toda a equipa.
Obrigado, Gustavo. Também quero agradecer a toda a equipa, agradecer novamente a Comissão Organizadora do VaP-APIC 2026. Esperemos que este caso tenha sido proveitoso. Bom congresso.
Bom, excelente live in the box. Parabéns à equipa de Gaia. Foi efetivamente muito pedagógico e de extraordinária qualidade. Nós ultrapassámos um pouco o tempo alocado, mas obviamente que não podemos dispensar aqui a intervenção do nosso painel e por isso começava já por desafiar a doutora Joana Rigueira e o doutor Luís Baquero a comentarem a opção terapêutica. Concordam com esta opção? Pensariam em explorar outras opções?
Eu se calhar poderia começar. Sim, eu concordo com a opção. Acho que aqui, efetivamente, tanto como se viu até pelo resultado final, isto é mais fácil comentar a posteriori, efetivamente foi uma boa opção. Gostava aqui de destacar, portanto, antes de mais, parabenizar a equipa pelo caso e pela excelente qualidade da imagem no caso, que infelizmente nem sempre temos qualidade de imagem tão boa. Mas destacar aqui, efetivamente, a importância também para o sucesso do procedimento da otimização da terapêutica em termos de otimização da volémia antes. Portanto, vocês fizeram com a titulação da metilazona e a titulação da furosemida, que já era bastante elevada e que, efetivamente, até pela nossa experiência também, até acaba por facilitar depois, pela redução do gap, acaba por facilitar o procedimento e, efetivamente, nós também achamos que isso é essencial.
Obrigado a todos. Parabéns à equipa de Gaia por este caso tão interessante e com tanto sucesso. Estou de acordo, obviamente, a técnica é impecável e melhor resultado ainda mais. Só queria dar duas pequenas notas. A primeira é que eu acho que estes doentes continuam a se referenciar muito tarde e visto o resultado tão favorável que têm com o triclip, acho que seria começar a pensar em referenciar os doentes antes de chegar a esse nível de medicação e de diuréticos tão forçada. E era importante também estudar, quando se faz a referenciação dos doentes, a função hepática e a elastografia hepática tem um papel importantíssimo nestes doentes, porque tem uma carga médica muito grande e, apesar de estar optimizada, nunca vai melhorar, porque a doença tricúspide é uma doença evolutiva e, portanto, chamou a atenção, sobretudo a cardiologia clínica, para referenciar estes doentes para a intervenção ou para as cirurgias, se for o caso, antecipadamente, adiantar-se um bocadinho este processo. Só isso. Obrigado.
Parabéns também à equipa pelo caso, pela seleção do doente e pela excelente qualidade de imagem. Pareceu fácil. Uma pergunta, às vezes não é tão fácil assim. Uma pergunta aqui para os cardiologistas de intervenção do painel, se concordam em termos de estratégia, como um plano logo pré-procedimento de apontar logo de início para 2 clipes em posição paralela, como se fez neste caso.
Boa tarde a todos e parabéns à equipa por este caso que foi super didático e reflete um bocadinho a experiência e a seleção adequada de doentes. Acho que isso é fundamental frisar. Como a Marisa disse, pareceu fácil e o facto de parecer fácil não quer dizer que seja realmente fácil. Do ponto de vista da estratégia, eu penso que nós temos, quando entramos nestes casos, temos sempre a ambição e a esperança de, com um só dispositivo, sairmos da sala. No ambiente tricúspide isso não é realmente frequente, há uma percentagem significativa, quase 50% pelo menos dos doentes que precisam de um segundo dispositivo. E aqui, não pelo resultado dentro do procedimento, porque dentro do procedimento, verdadeiramente, eu acho que vocês, como expoliaram os doentes, secaram, ele não tinha sequer ainda, já não tinha uma insuficiência tricúspide grave nesta fase, portanto foi difícil perceber o valor do segundo dispositivo que é feito à luz do ecobasal, mas não do intraprocedimento. Por isso faz sentido à luz do ecobasal, não dentro do procedimento, porque dentro do procedimento parecia que chegaria. Foi esse, e eu acho que isso também reflete outra vez a experiência da equipa de fazer diuréticos para os doentes, para tornar o procedimento mais executável, mais fácil e conseguir melhores resultados em menos tempo, também a eficiência do procedimento.
Eu penso que a média de implantações na tricúspide é 2.4, enquanto que na mitral é 1.7. Portanto, a tricúspide exige mais clipe para um bom resultado. Acho que é um caso muito clean, muito bem feito. Uma nota ao que o Baquero diz. Este é o doente ideal, é um triscore médio-baixo, e o triscore já incorpora as bilirrubinas, portanto, a função hepática. Portanto, essa informação foi integrada neste paciente.
Eu tinha um comentário, de facto, este caso, pronto, obviamente foi muito bem selecionado em termos de execuibilidade. Eu concordo com o Duarte no sentido em que, na maior parte das vezes, um clipe na tricúspide não chega, e acho que tem sido um problema nosso sermos menos exigentes no edge-to-edge em termos de resultados. E depois, quando começamos a ver os doentes na consulta, de facto, os doentes do edge-to-edge que melhoram clinicamente são aqueles que conseguiram uma redução muito significativa. Eu acho que aquela coisa de passar de torrencial a grave, e já consideramos isso um sucesso parcial, acho que já não podemos continuar a aceitar isso. Acho que temos que ser muito exigentes com os doentes tricúspides, e nota-se diferença, e agora que temos a experiência da substituição valvular, ainda mais notamos isso, que os doentes melhoram quando melhoram a insuficiência tricúspide, obviamente quando não tinham um ventrículo direito muito mau à partida. Acho que devemos ser mais exigentes no resultado inicial.
Excelente. Marisa, muito obrigado a todos. Encerramos esta parte do Live in a Box e convido desde já o Dr. Luís Puga a fazer a sua apresentação sobre as melhores estratégias de imagem para termos sucesso na intervenção tricúspide.
Então, boa tarde a todos novamente. Apenas agradecer, relativamente ao caso anterior, as amáveis palavras de todos os operadores experientes pelo sucesso deste caso. Relativamente a esta comunicação, agradecer também à comissão organizadora, não só o convite, mas também a escolha do tema. Achei muito interessante a escolha destas palavras, da complexidade à clareza, que acho que é, no fundo, o que nós tentamos fazer com a imagem. E, portanto, a minha visão, para conseguirmos o sucesso da intervenção, a imagem tem que ter um papel muito antes da intervenção, no screening, no planeamento, obviamente guiar o procedimento, mas também depois a imagem não acaba no procedimento. Também temos que acompanhar os doentes e continuar para que o tratamento seja duradouro. Relativamente ao screening, nós temos este fluxograma step by step da Sociedade Europeia de Cardiologia, nas guidelines, que, reparem, quase todos estes pontos precisam de imagem. Nomeadamente ecotranstorácico, transesofágico, TAC e também cateterismo direito. Acho este esquema muito bonito, mas vou-vos confessar que na prática não é exatamente isto que estamos a fazer. Acho que não temos cadência para avaliar o doente consulta a consulta e fazer tudo passo a passo. Vou-vos propor uma estratégia semi-alternativa, digamos assim, em que nós, com estes dois primeiros passos, com uma avaliação clínica cuidada, analítica e com um bom ecocardiograma transtorácico, conseguimos muitas vezes perceber se o doente vai ser candidato ou não a uma intervenção transcatéter. E daqui pedir uma série de exames que poderão ser como uma bateria pré-intervenção e que vamos avaliá-los a todos de uma forma complementar e um bocadinho simultânea. Vamos retirar destes exames aspectos para todos estes passos do fluxograma. E depois daqui, obviamente, saltamos para o ART-TEAM e tomamos as decisões já com todos estes dados. Mas o que vos vou tentar mostrar nos próximos slides é que não é tudo passo a passo. Vamos tirando informações de vários pontos deste fluxograma. Obviamente que a avaliação da função direita é fundamental e, principalmente, perceber que os doentes com disfunção direita avançada não são bons candidatos a estas terapêuticas, têm pouco benefício, já têm uma fase muito avançada da doença. Os doentes que já perderam o acoplamento ventrículo direito artéria pulmonar, também está demonstrado que beneficiam pouco de estratégias de transcatéter. E também está demonstrado um score que é bastante simples, que se consegue correlacionar com bons resultados de reparação edge-to-edge. E, no entanto, este é uma excelente ferramenta para nós decidirmos se vamos para edge-to-edge ou para substituição por prótese. O que é que a imagem nos pode dar de uma forma muito objetiva no screening? Dimensões do anel, a qualidade dos folhetos, a anatomia, se há restrição dos folhetos, o tamanho do gap, a densidade dos músculos papilares, também a importância da quantificação, que é fundamental, e perceber sempre em que dados hemodinâmicos é que esta quantificação foi feita. Se temos um doente que está com pressões altas, que está sob anestesia geral, sob propofol ou midazolam, se está em sobrecarga de volémia, é sempre fundamental sabermos com que passo é que foram feitas estas medições. Identificar também outros aspectos, como eletrocatéteres, que podem dificultar os procedimentos. É bom ter uma boa qualidade de imagem e nós podemos, com imagem, tentar simular como é que vai ser a imagem, obter um bom transgástrico profundo. O TAC pode nos ajudar no ETE. E, obviamente, a anatomia, nós estamos a fazer um screening, mas também já estamos a pensar no planeamento, no fundo. Já estamos a olhar para quantos folhetos há, qual seria uma hipotética estratégia de um edge-to-edge. E, portanto, estamos a fazer screening, mas também estamos a fazer planeamento. E não esquecer que estamos a fazer um ETE de screening, mas que também já estamos a pensar que se o doente for fazer a intervenção, vai estar em decúbito dorsal. E, portanto, recomendo que se vire sempre por sistema os doentes para decúbito dorsal e gravar algumas imagens com a informação do decúbito dorsal para termos a imagem replicada do que vai ser dentro da sala. E, portanto, estamos a fazer um screening, mas já estamos a planear, já estamos a obter dados para o que poderá ser uma hipotética intervenção. E o planeamento também envolve muito o TAC, e reparem que com o TAC também conseguimos ver o anel, os folhetos, conseguimos inclusive fazer quantificação. Reparem que a área efetiva por TAC correlaciona-se com a área efetiva identificada por eco, portanto é mais uma ferramenta. Podemos identificar também os folhetos e as comissuras pelo TAC. Podemos inclusive ver, portanto, qual é a estrutura dos músculos papilares, onde é que eles estão, se são próximos da válvula, se são profundos, se temos 1, 2, 3, se temos músculos papilares septais, que é uma coisa rara, mas que pode dificultar a intervenção. E podemos, inclusive, planear o trajeto dos nossos catéteres para a intervenção. É verdade que isto é imprescindível para a substituição valvular, mas também é útil para a reparação edge-to-edge. Nós também podemos ver no edge-to-edge qual vai ser a altura dos nossos catéteres, se temos uma veia cava inferior muito desalinhada do anel da tricúspide e se vamos ter que fazer manobras de compensação adicionais. E podemos inclusive ver, reparem na imagem da esquerda, a restrição do folheto septal por TAC. E, portanto, estamos a tirar informação de planeamento, mas também de screening. No fundo, isto é tudo um bocadinho em simultâneo. Este foi o caso que viram do Live in the Box. Eu gosto de, no planeamento, conversar com a equipa, demonstrando o que é que eu acho que são as comissuras e, com base nisto, qual é que será a estratégia proposta, que neste caso foi esta. E, portanto, isto é uma forma simples de comunicar e de demonstrar o que é que achamos e estamos todos na mesma página no que diz respeito à estratégia. E também no eco podemos ver também os músculos papilares. Reparem, por eco, neste corte, a interação do dispositivo com o músculo papilar, que é uma coisa que pode dificultar-nos o procedimento, pode dificultar-nos as manobras de rotação ou de aproximação de um dos lados da válvula. E depois temos ainda a possibilidade de contar com o apoio da indústria, neste caso da Edwards, que se nós enviarmos os relatórios, portanto os exames em DICOM, recebemos um relatório pormenorizado por quem faz isto, se calhar, dezenas de vezes diariamente, e podemos aprender também e olhar para estas informações e ajudar também a tomar decisões com elas para o ART Team. Ou seja, estamos a planear, mas também estamos a usar informações de screening. E depois temos o guidance da intervenção. Obviamente que a imagem tem um papel muito importante nas diversas intervenções. Gostava de mostrar este caso de aneloplastia, que infelizmente este é um programa que está interrompido, mas como a imagem pode acompanhar o procedimento, planear. Reparem na fusão com TAC, onde temos planeados onde vai ficar cada uma das âncoras, qual é a relação com a válvula, com a coronária direita. E reparem na imagem da direita, como uma simples imagem 2D, estamos a acompanhar o implante de uma das âncoras até ao limite do coração. Portanto, está quase a tocar no pericárdio, mas não ultrapassou o pericárdio, e, portanto, estamos a controlar detalhes importantes para a intervenção. Isto é o resultado, o antes e o pós. Isto é um caso de implante de prótese tricúspide, neste caso a Lux Valve. Reparem como o planeamento por TAC também pode ajudar no guidance. Temos desenhado na linha roxa 4 cm abaixo do plano do anel tricúspide, que vai ser mais ou menos o nosso espaço de trabalho onde vamos manobrar os catéteres. Reparem que temos a verde segmentado o ventrículo direito e os músculos papilares e aquela trama onde vamos trabalhar, o anel da tricúspide, e a laranja temos um plano 1 centímetro acima onde vai ficar a fralda da prótese. E este é o resultado antes e o depois deste caso. E também aquilo que fazemos mais frequentemente, que é o edge-to-edge na área da tricúspide, onde a imagem vai, mais uma vez, assumir um papel fundamental para a posição do nosso dispositivo, a orientação, e temos que também garantir, tal como nesta imagem da direita, a captura adequada dos folhetos. Temos que garantir que, efetivamente, estamos no local certo, a apanhar a quantidade certa de folheto. E neste caso acabamos com 3 dispositivos Pascal, com também um resultado que consideramos satisfatório, com um bom grasping dos folhetos. E este, em cima à direita, era a imagem do antes. Mas a imagem não termina quando o doente sai da sala. Nós temos que, de facto, conhecer que dispositivos é que implantamos aos nossos doentes e temos que os acompanhar para fazer com que estes resultados sejam duradouros. E, portanto, há uma série de coisas que devemos continuar a vigiar e que a imagem vai ter também um papel central. Peço desculpa as imagens não estarem a correr, mas à cabeça, na imagem da esquerda, no implante de prótese tricúspide, de forma imediata, temos que avaliar a função do ventrículo direito, e agora já está, e, portanto, uma disfunção direita, que é mais ou menos a regra neste tipo de casos, podemos monitorizá-la, podemos quantificá-la, e isto pode ajudar a tomar decisões, juntamente com a parte clínica e hemodinâmica, sobre dar outro tipo de suporte inotrópico, inodilatador, um curso de milrinona, e a imagem pode ajudar também nesse aspecto, mas também, na imagem da direita, a longo prazo, seguir complicações. Neste caso, vemos um caso de um partial detachment, de um single leaflet, de um SLDA, e, portanto, a imagem, mais uma vez, quando há algum agravamento clínico, tem que acompanhar este tipo de complicações e, portanto, são doentes que devemos manter a carga terapêutica otimizada para também tentarmos evitar este tipo de situações. Reparem noutro tipo de possível problema na prótese tricúspide. Neste caso, vemos um doente com um gradiente transprotésico tricúspide médio de 5 e com uma válvula que, de novo, tem uma insuficiência intraprotésica, que não é catastrófica, mas que demonstra que algo não está bem neste caso. E reparem no TAC, em que demonstra um halt severo, no fundo, uma hipotenuação muito importante dos folhetos, com espessamento, com redução da sua mobilidade, e isto implica, obviamente, uma alteração terapêutica. Ser mais agressivo na anticoagulação, neste caso mudamos de regime de NOAC para varfarina e intensificamos os INRs, e estamos a acompanhar também este doente, mas são complicações que temos que estar atentos e saber segui-las. Não chega a pôr uma prótese e mandar o doente à sua vida. E reparem neste caso de eco, em que a imagem da esquerda pode parecer tudo aparentemente normal, mas se olharmos com mais atenção, vemos que há um folheto protésico que parece de facto estar imóvel e que na sua base está um bocadinho espessado. E este doente já tem gradientes transprotésicos entre 3 e 4 e devemos alertar que alguma coisa aqui pode não estar bem e, mais uma vez, rever a estratégia anticoagulante. O doente adere à estratégia, devemos mudá-la, devemos intensificá-la e, portanto, a imagem aqui a promover melhoria de outcomes clínicos. E, mais uma vez, num caso de prótese tricúspide, reparem, a imagem da esquerda parece um resultado adequado, pode haver um pequeno leak, não há grande turbulência na prótese, mas se explorarmos janelas alternativas, neste caso é um subcostal, um eixo curto, vemos que há ali um fluxo anormal e vemos que há um leak que não é assim tão pequeno, não é uma coisa grave, mas também devemos estar atentos e vigiar e perceber qual vai ser a evolução disto, se vai ter impacto analítico, se vai ter impacto em termos de hemólise, e, portanto, mais uma vez, a imagem a permitir o acompanhamento destes doentes. E, portanto, estas são as minhas mensagens finais. No fundo, a imagem vai tentar transformar complexidade em clareza, vai estar envolvida em todos estes passos, desde o pré, o durante e o pós, e o objetivo é nós, no screening, escolhermos os doentes certos, escolhermos o timing certo, no planeamento, escolhermos o dispositivo certo e a estratégia certa, no guidance, promover um implante seguro, sem complicações, correto, e no pós, garantir uma monitorização contínua adequada para, no fundo, melhorar os outcomes clínicos. É isso que nós queremos. Obrigado pela atenção.
Muito obrigada, Dr. Luís Puga, por esta apresentação tão esclarecedora. Eu penso que nós vamos ter tempo para discutir as 3 comunicações depois no final. Vamos passar agora à apresentação do Dr. Manuel Oliveira Santos sobre este dilema que penso que todos temos, reparação ou substituição valvular percutânea.
Muito obrigado, doutora Brisa. Boa tarde a todos. Obrigado pelo convite. Muito bem, então eu venho aqui apresentar qual é a minha opinião pessoal e da minha instituição sobre o melhor algoritmo para decidir entre reparação ou substituição valvular. E começo já com o outline da apresentação, com o algoritmo em si. O algoritmo começa a encontrar aqueles doentes que já foi aqui referido, provavelmente já não beneficiam da intervenção tricúspide. Nós vemos olhar para os dados clínicos de eco. E agora, de facto, as novas guidelines são muito claras quais são os doentes que nós não devemos tratar com esta técnica, porque já estão um bocadinho ultrapassados. Mas, passada esta fase, temos então que saber definir anatomicamente se o doente é bom candidato para TIR ou para substituição valvular. E para andar por este algoritmo assim de uma forma mais didática, eu trago aqui apenas um caso clínico para a apresentação em que podemos avaliar todos estes dados. Este foi um senhor que eu conhecia há 3 anos, com 75 anos, FA permanente, foi referenciado a um hospital de outra área por uma insuficiência tricúspide grave, sintomática. O doente tinha dispneia de esforço e edema dos membros inferiores. O eco tinha um bom fenótipo, o doente tinha um ventrículo dilatado, mas com função preservada por todos os índices. Também do lado esquerdo não tinha outras alterações valvulares, boa função ventricular esquerda, tinha um excelente estado geral e tanto a parte renal como a hepática não tinha nenhuma alteração. E partilho convosco então as imagens do eco transesofágico, que confirmava então a gravidade, na verdade uma insuficiência tricúspide torrencial. Aqui o mecanismo parecia misto auricular-ventricular, tinha um gap relevante de 7 mm central e, portanto, voltando a este doente, é um doente de facto com indicação. Em termos clínicos não há aqui nenhuma futilidade, não há nenhuma disfunção de órgão. E também não há sinais de disfunção grave do ventrículo direito. Na verdade, nesta fase, nós não fazíamos o cateterismo direito por rotina a todos os doentes, mas ele não tinha um sinal de ter uma hipertensão pulmonar grave e, portanto, passamos logo ao passo seguinte, olhar para o ETE de forma crítica e perceber onde é que ele se enquadra. E, como já foi aqui falado, o glide score, de facto, é uma forma muito simples de tomar essa decisão. Este slide também já ouviram, só referir que vamos dar 1 ponto por cada uma destas características, se for complexo. E este score, na verdade, já foi validado numa população externa e tem uma área sob a curva de 0,77 para discriminar entre estes 3 grupos. Portanto, é interessante. Ou seja, se o score é muito baixo, há 90% de probabilidade de termos um bom resultado, entre 0 a 1. Se o score for entre 2 e 3, temos 50% de probabilidade de sucesso. Portanto, já é outro campeonato. Idealmente é de referenciar o doente para um centro de elevada experiência. Se o glide for muito elevado, se calhar mais vale não fazer TIR, porque de facto os resultados só há 15% de probabilidade de sucesso. O nosso doente tinha aqui um score intermédio entre 2 e 3, portanto o tal gap de 7, já tinha aqui um bocadinho mais star-shaped. Na verdade, nós na altura não tínhamos outra técnica, portanto decidimos avançar com a reparação com TIR. E mostro aqui rapidamente o procedimento. Portanto, mostro só aqui a fase final. Tentámos, como habitual, várias zonas de grasping, aquela que pareceu melhor, utilizámos um clipe à escala S, e aquela que pareceu melhor foi uma posição anteroceptal mais central. E como podem ver em termos agudos, aqui à direita temos um resultado também muito bom, com uma insuficiência mínima. O doente teve alta no dia seguinte sem qualquer complicação, e o eco antes da alta, o eco transtorácico, como habitual, mostra um grau um bocadinho superior, e falávamos de uma insuficiência tricúspide residual ligeira a moderada, com boa função ventricular direita. Portanto, ficámos bastante satisfeitos com o resultado deste caso. E, na verdade, quando vamos ver a literatura que deu origem à indicação que nós utilizamos hoje em dia, os resultados dos ensaios, de facto, são muito bons. Do lado esquerdo, temos aqui um sumário do Triluminate para o TIR. Do lado direito, temos os resultados do Triscend para a substituição. E logo aquilo que chama para a atenção é que os dois foram positivos, sobretudo no efeito de melhoria de sintomas, mas, de facto, a substituição valvular, como é expectável, é muito mais eficaz. Tem 99% de eficácia para atingir uma insuficiência tricúspide moderada ou menos, enquanto o TIR só tem 88%. E o que é interessante é que isto tem relevância clínica. Portanto, os doentes do Triscend, obviamente não estamos aqui a comparar estes grupos, o ensaio não foi o mesmo, mas no Triscend houve uma melhoria da qualidade de vida superior, provavelmente devido à melhor eficácia. Contudo, há uma fatura a pagar. E reparem aqui nos dados de segurança. Basicamente, a utilização de prótese, isto é um bocadinho, tem a ver também com as outras áreas de intervenção na cirurgia cardíaca, por exemplo. O doente que coloca uma prótese tem 3 vezes mais probabilidade de ter um evento adverso, tem 6 vezes maior probabilidade de precisar de um pacemaker e também 3 vezes maior possibilidade de sangrar. Não só porque provavelmente já são doentes um bocadinho piores, mais remodelados, com mais função hepática, mas também porque, como já vimos, precisam de anticoagulação lifelong. E, portanto, com base nestes dados, obviamente, se o doente é um bom candidato a TIR, é, sem dúvida nenhuma, ao dia de hoje, a nossa primeira opção, que foi aquela que nós fizemos com este doente. Contudo, podemos complicar um bocado e podemos olhar para o trajeto habitual e a história natural da insuficiência tricúspide. E se estamos mais do lado esquerdo desta pirâmide, portanto, doentes com insuficiência não tão torrencial, com ventrículos ainda não muito dilatados, sem dúvida que o TIR será uma boa hipótese para começar. Mas depois há ali um sweet spot a meio, que é o sweet spot da substituição valvular, que é o doente que já tem uma insuficiência tricúspide muito grave, uma insuficiência torrencial, com ventrículo dilatado, mas ainda com função preservada. Aqui é aquela coisa que, se tivermos uma terapêutica que reduz 100% a insuficiência, provavelmente vai ter impacto prognóstico não só nos sintomas, mas noutros dados. Contudo, se cruzamos esta curva e estamos do lado direito, aqui podemos começar a fazer mal ao doente, porque se há uma disfunção ventricular direita relevante e colocarmos uma prótese, ele pode piorar no pós-procedimento. Portanto, devemos ter muito cuidado em afastar-nos aqui deste lado direito. Agora, eu trago este caso porque, obviamente, ele não era linear e, para dar para a apresentação toda, tinha de ter aqui alguma complexidade. Eu depois vi o doente 6 meses depois do procedimento e o doente contou-me que, de facto, ficou muito melhor no início, mas foi relativamente súbito, mais ou menos 2 meses depois do procedimento, ele começa novamente com dispneia de esforço e edema dos membros inferiores. Ele veio ao próprio laboratório de eco, fiz eco e pareceu-me que a insuficiência tricúspide era pelo menos moderada naquele momento e eu, por transtorácico, fiquei na dúvida se não havia ali algum detachment. Portanto, o clipe pareceu-me andar demais. Eu tranquilizei o doente e disse que o próximo passo seria fazer um eco transesofágico, porque havia a possibilidade de voltar ao procedimento e colocar um segundo clipe para melhorar os resultados. E este é aqui umas imagens que selecionei do ETE depois deste controlo. Neste ETE não parecia haver um detachment, o clipe estava aderente ao folheto anterior, ao folheto septal, mas havia uma regurgitação relevante posterior ao clipe implantado, portanto a confirmar que de facto o resultado tinha piorado. E nós sabemos de facto que com o TIR até 20% dos doentes podem ter agravamento do resultado no follow-up, portanto não é totalmente de estranhar este resultado. E um bocadinho de acordo com aquilo que a doutora Marisa estava a dizer há pouco, nós sabemos hoje em dia que de facto vale a pena ser eficaz. E há aqui esta regra do 3, baseado neste estudo que incluiu já mais de 1000 doentes tratados com estas terapias, que o doente melhora clinicamente quando reduz 3 graus na sua insuficiência. Portanto, devemos tentar sempre ter uma insuficiência ligeira ao menos, com uma exceção, os doentes com torrencial, de facto, se atingir a moderada, dá a ideia que já tem um grande benefício. E, portanto, neste doente nós estávamos mais ou menos nesta regra dos 3, mas claramente o doente tinha agravado com este resultado subótimo. Portanto, ponto para parar e pensar, quais são as opções que temos para melhorar este resultado? Em primeiro lugar, acho que todos concordam, a melhor opção, aquela mais direta, é voltar à sala e colocar um segundo clipe para melhorar o resultado. Obviamente que o doente pode até não querer, pode ter perdido a confiança e a terapêutica médica pode ser um recurso. Aliás, eu logo naquela consulta o doente estava apenas com diurético de dança, iniciei de imediato aldactone para tentar melhorar ali um bocadinho a congestão. Entretanto, o tempo passou e temos também outra solução. Podemos pensar com algumas manobras, colocar uma válvula no doente, ou, se a situação evoluir muito e não tivermos nenhuma hipótese anatómica e o que dominar o fenótipo for a congestão, temos também a terapêutica das bicavas, que pode ajudar um bocadinho neste contexto. Portanto, se estamos a considerar o replacement, aqui há outras considerações. E estão aqui 2 esquemas, assim um bocadinho artísticos. Portanto, do lado esquerdo temos o TEER. O TEER faz uma anoplastia dinâmica. Terá pouco impacto, não tem nenhum efeito negativo sobre o ventrículo direito. Do outro lado temos a prótese. A prótese é muito eficaz, mas é uma estrutura rígida que vai fixar o anel e fixar também a base do ventrículo direito. E, portanto, além de ser 100% quase eficaz em tirar a insuficiência, também pode agravar um bocadinho a função ventricular direita e isso pode dar problemas devido ao aumento súbito da pós-carga no procedimento. Portanto, devemos ter este ponto em mente. Portanto, sempre que considerarmos a implantação de válvulas, na verdade, em todas as terapêuticas tricúspide, mas especificamente quando se implanta válvulas, temos de olhar para o pulmão, para o coração e, sobretudo, para a interação entre o coração e o pulmão. E a métrica mais fácil de utilizar, o sinal mais fácil, é olhar para o acoplamento entre o ventrículo direito e a artéria pulmonar. Basicamente, é uma medida de quão o ventrículo direito ainda está capaz de lidar com aquela pós-carga aumentada com a hipertensão pulmonar. Isto é determinado invasivamente, ninguém faz estas determinações. O mais fácil é fazer um rácio muito simples, dividir a TAPS pela PSAP. Podemos fazer isto só com eco, mas fica mais enriquecido. Como sabem, em ciência tricúspide, o eco pode subestimar a PSAP, portanto fica mais enriquecido se incluirmos os dados do cateterismo direito. E depois, assim, de forma binária, se este valor der 0,3 ou menos, sabemos que o doente já tem algum grau de desacoplamento e pode piorar depois da intervenção. E surgiu então este conceito, que aliás existe nas outras áreas valvulares, mas é da reserva da pós-carga, que se for baixa, de facto o doente pode ficar pior depois do replacement. E nós, na verdade, temos um caso para partilhar da nossa experiência inicial, foi o pior caso que nós tivemos de replacement. Foi este doente já muito grave, de 84 anos, que nos foi referenciado já em fase um bocadinho quase paliativa, já tinha redução da função sistólica biventricular, mas tinha um problema que, de facto, estava sempre internado noutro outro hospital por congestão. Como veem, tinha já uma hipertensão pulmonar ligeira, mas, sobretudo, a tal medida de acoplamento era baixa, de 0,3. E reparem, o procedimento foi um sucesso, portanto, a válvula ficou implantada, mas comparem ali o coração à esquerda e à direita. Depois de implantar a válvula tricúspide, o ventrículo direito dilatou, entrou em disfunção, o doente perdeu logo pressões. E reparem o ventrículo esquerdo, se puderem pôr esta imagem, este vídeo a andar outra vez, por favor. O ventrículo esquerdo, que era pequeno e com uma insuficiência mitral ligeira, de repente ficou com uma disfunção grave e com uma insuficiência mitral grave. Isto logo agudo. Diuréticos, levou alguns dias a considerar alto este doente, um percurso mais complicado e, portanto, ficámos bem com a lembrança desta problemática de facto, ter de selecionar muito bem os doentes para esta terapêutica. Ainda assim, a nossa experiência é boa, eu partilho aqui os dados, já temos 24 EVOCs implantadas no nosso centro, eu mostro só os dados que nós temos dos primeiros 18 doentes, uma população com 80 anos, com a função ventricular direita preservada, na verdade tem hipertensão pulmonar, tem uma pressão média de 23 na artéria pulmonar, resistências de 2,5, mas um acoplamento favorável que nós tentamos incluir estes doentes para ter um bom seguimento. E a verdade, o nosso sucesso é de 100%, o tempo de admissão média é de 4 dias. Esta é aquilo que acontece à insuficiência tricúspide, reduz de forma muito significativa em todos os doentes tratados. Não tivemos mortalidade, tivemos necessidade de implantar pacemaker em 2 destes 18 doentes e tivemos estas complicações, um tamponamento resolvido de imediato e 2 hospitalizações por insuficiência cardíaca. Portanto, estamos satisfeitos com a aplicação desta técnica. Voltando ao nosso caso, então, nós temos um doente que é algo complexo para implantar um segundo clipe, temos até alguma dúvida da estabilidade do clipe que nós pusemos previamente e, portanto, o doente fez screening para replacement, fez um ataque para ver se o anel e o ventrículo direito podiam, então, levar a prótese, fizemos um cateterismo direito para ter a certeza que não havia desacoplamento e tem tudo bem, e é um doente que já está anticoagulado e nós sabemos que tem boa tolerância. Até fizemos um bocadinho mais, nós com o ETE não ficámos totalmente esclarecidos sobre o efeito e a qualidade do grasping anterior. Fizemos aqui um ICE, na altura ainda não tínhamos ICE 3D, Dá aqui uma imagem muito clara, um bocadinho difícil de orientar só com o 2D, mas a noção com que nós ficámos é que o clipe anterior, o Pascal, tinha tido alguma migração ventricular, portanto houve certeza algum detachment, tinha algum tilt lateral e, portanto, mais uma vez, não estávamos muito confiantes do resultado a longo prazo e da possível interação ao tentar implantar um segundo clipe. E, portanto, a decisão, tendo em conta que, com base neste ataque, o doente era candidato a colocar uma EVOC de 48 mm, portanto, nós avançámos para o procedimento. Claro que é preciso fazer mais qualquer coisa, não é? Há um clipe a fechar aquela válvula. Portanto, eu mostro-vos aqui o procedimento de Esta, em que utilizámos apenas um acesso de 26 frentes, e através dessa bainha de dry seal de 26 frentes colocámos 2 agilis e um loop com uma guia a estátua através das 2 agilis. E depois o procedimento é tentar colocar esse loop da guia a estátua imediatamente na inserção lateral do clipe previamente implantado. O ideal é fazer a laceração lateral para o clipe ter um displacement para a zona septal. E, portanto, bastou uma aplicação de 70 watts para, como veem, ele ficou ali bem agarrado ao folheto septal e viam ali na imagem da ETE no canto inferior direito e, portanto, estava fora agora do nosso campo e podíamos avançar para a implantação da válvula. Até em termos técnicos, aqui para os hemodinamistas, temos agora ali uma marca, sem a imagem de fusão do Puga, temos ali uma marca que nos mostra bem onde é que está o anel e fazemos uma libertação lenta da válvula que capturou o folheto com um bom resultado e este doente, de facto, era muito bom candidato a replacement e evoluiu muito bem. Para finalizar, só aqui uma pequena nota para os doentes que, só por terem uma pacing lead, são doentes, de facto, mais problemáticos para a intervenção. Sabemos que os TIR, neste contexto, são relativamente complexos e os dados da EVOC com pacing leads enjauladas até são surpreendentemente bons. Isto já há aqui uma série com 100 doentes em que foram analisar o que é que acontecia quando se punha uma EVOC e ficava com o elétrodo enjaulado. E, na verdade, há 6 meses, a disfunção do elétrodo foi apenas em 5% dos doentes. Portanto, há alguma segurança em fazer isto. O único problema é que, de facto, aumenta a probabilidade de leak tricúspide quando se faz isto. E, obviamente, temos de ter aqui uma colaboração multidisciplinar com o setor de pacing. Mas é algo devido à nossa experiência com TIR em eletros. Temos agora optado mais em pensar em substituir estes doentes. Conclusão. Antes deste procedimento, devemos olhar para estes esquemas, devemos tentar perceber qual é a melhor técnica para oferecer aos nossos doentes. Eu resumia com este slide. Portanto, quando temos um doente com bons folhetos móveis, de comprimento adequado, um gap inferior a 7 mm, mesmo que o doente tenha alguma fragilidade, mesmo que o doente já não tenha o ventrículo direito com a melhor função, provavelmente é um bom candidato a TIR. Por outro lado, se temos um score glide elevado, um gap de coaptação mais que 10 mm, sobretudo para aqueles doentes com insuficiência torrencial, mas que ainda o ventrículo tem uma função preservada, devemos seguramente pensar em replacement. Obrigado.
Manuel, muito obrigado. Excelente apresentação e convidava agora o Dr. Ângelo Sanches a ensinar-nos como resolver casos difíceis, sobretudo complicações, na substituição tricúspide. Obrigado.
Muito obrigado aos organizadores polo amable convite a participar neste simposio. Teño que escoller entre falar en español, falar inglés e falar galego, que é moi parecido ao portugués. Prefiro falar galego, que é a miña lingua materna. Que, bueno, vamos a empezar a falar da sustitución valvular tricuspidia. É un procedimento moito sencillo, moito simple, como sabéis, pero moitas veces temos que enfrentarnos a anatomías que son complexas, pacientes con mala imaxe, pacientes con electrodos, que teñen intervencións previas, pacientes con enfermedade reumática da válvula tricúspide, e complicacións como é a posible embolización ou a mala posición da prótese cando hai un leak, e sobre todo cando hai tamén complicacións non solamente intraprocedimento, senón despois do procedimento, como pode ser a trombose, a disfunción do ventrículo dereito, cando empeora a insuficiencia mitral, a potencial riesgo de endocarditis, que temos que valorar sempre cando elegimos este tipo de tratamento. Entón, empezo con un caso que vemos habitualmente, que son pacientes, como veis, que non sei se ve, sí. Son pacientes que, en este caso, o problema é a mala imaxe. O sea, cando temos unha mala imaxe é moi difícil facer este tipo de procedimentos. En este caso, podeis fixaros que temos unha prótese mitral mecánica e non podemos ver prácticamente nada a nivel septolateral. É un problema, no? Isto a nivel, aquí está, temos a imaxe mediosofáxica, esta é a imaxe intragástrica. Temos un problema, cando facemos o MPR, pois é moi difícil valorar o que sería septolateral, aunque podemos ver anterior e posterior do anel tricuspidio, pero é moi difícil. Nestes casos, temos que fiarnos no eco intracardíaco, que é unha arma que cada vez debemos de usar máis cando tratamos tricúspides, e podemos facer un MPR e poder estar seguros de que realmente a posición da prótesis é correcta. Este é un caso onde temos un doente con dúas próteses mecánicas, mitral e aórtica. En isto xa podemos prever que no eco transofáxico vamos a ter problemas para ver os folletos e o anel na parte anterior e na parte septal. E aquí estamos, este é o TAC, onde se ve que é unha válvula reumática, como veis, como abre a apertura en cúpula, son folletos moi engrosados. Durante o implante, aquí xa estamos na fase ventricular do implante da prótese VoC, e en principio era complicado ver todo o que sería a parte anterior e a parte septal do anel tricuspidio. En este caso, usamos moitas veces de forma complementaria o eco intracardíaco. Neste caso non temos o 4D, pero temos o bidimensional. E fijaros como vemos moi ben como os folletos caen dentro da prótese a nivel septal, a nivel lateral, pero temos moitas dúbidas que pasa o mismo a nivel anterior. Onde está a flecha, non sei se podo señalar con isto, non creo que non, xa sí. Onde está a flecha, fijaros como hai unha parte aquí que este é o folleto, que vemos que non sabemos realmente se está dentro ou está fora. Bueno, o que fixemos foi baixar a válvula, ir máis abaixo, irnos á parte anterior, intentar facer o grasping da parte anterior, que tiñamos dúbidas, pero fixaros ao final como a válvula non estaba ben feito grasping, e o que é a nivel anterior septal, pois houve un pequeno deslocamento da válvula e foise para o ventrículo dereito. Aquí veis por eco intracardíaco a imaxe da válvula que está deslocada, e ten un leak paravalvular moderado, severo, e o mismo veis na imaxe do eco transofágico, tamén no eco transtorácico. E, bueno, neste caso, cando temos unha mala posición ou que temos un bolisosao ou un deslocamento da válvula, pois é unha complicación que é grave. Entón, bueno, neste caso a válvula non estaba moi móvil, estaba bastante fixa, pero podemos non facer nada, esperar, mandar a cirurxía ou intentar non facer un valve-in-valve. Neste caso, a opción é, deixámoslo tal cual estaba, logo un jartín, discutimos o caso, e ao final, entre o cardiólogo clínico, a xente de imaxe, nosotros, ao final, optouse por mandar a cirurxía porque tiña cada vez o leak que tiña periprotésico era maior. Pero probablemente non foi a opción máis correcta. Probablemente o que tiñamos que facer é intentar facer un valve-in-valve. Quer dicir que pódese facer, presenta un caso que é moi parecido ao noso caso, este é un caso de Palo Alto, de California. Veis como liberar a prótese migrou dentro do ventrículo dereito, veis un leak paravalvular bastante importante a nivel anterior, septal. Este, un deslocamento maior que co noso caso. E fijaros como o primeiro paso é non perder a guía. Non perder a guía porque se perdemos a guía, pois cando temos que volver a pasar por dentro da prótese, pois podemos mobilizar a prótese. Con lo cual, o primeiro, non perder a guía, o segundo é un segundo acceso, con un lazo cazar a válvula para inmobilizala, para prever ou para evitar que vaya dentro do ventrículo. E, en segundo lugar, pois podese pasar unha válvula que neste caso é unha SAPIN número 29 e colocala a nivel máis auricular para evitar o paravalvular leak. Co que eu penso que é moi importante cando hacemos tipo de procedimentos ter en reserva e ter a mão unha válvula SAPIN número 29, porque en casos de ter non unha embolización completa dentro do ventrículo, pero en caso de ter un deslocamento, pois podemos resolverlo dunha forma bastante sencilla do que estamos acostumbrados. Neste caso, logo antes do final deployment, temos que retirar, lógicamente, o lazo, o snare, que veis aquí. Isto é tal como quedou a válvula colocada. Esta imaxe da ecocardiografía transofáxica explicaise como construir de novo unha chimenea que co falda, co recubrimento da prótese aórtica podemos sellar o paravalvular, que neste caso quedou un leak paravalvular, pero un leak paravalvular leve, e a prótese quedou moito máis estável do que estaba ao principio. Outro tema importante, como dixo Manuel previamente, son pacientes que teñen electrodos. Os electrodos de marcapasos é un problema a hora de planificar o procedimento. Sabemos que unha terceira parte dos pacientes que tratamos con prótesis teñen marcapasos e, son procedimentos que poden ter o risco do deslocamento do electrodo, que a mala función do electrodo despois de implantar a válvula, o risco de ter unha endocarditis, a dificultad de extraer os electrodos cando están atrapados coa válvula, existe máis riesgo de embolización, máis riesgo de un paravalvular leak, e tamén temos bastantes sombras acústicas co electrodo que nos pode dificultar o procedimento. O primeiro é analizar con TAC, como dixo Manuel, moi ben, analizar con TAC o slack, a longitude do electrodo. Neste caso, vemos unha longitud limitada. Neste outro caso, temos un adecuado slack, unha adecuada longitud, con o cal temos menos problemas. Podemos enfrentarnos a doentes que teñen un micra, un pacemaker, un leadless pacemaker. E a veces nos enfrentamos a casos complexos, porque este era un caso que vou presentar agora, que me parece bastante curioso, bastante interesante. É un paciente de 81 anos que tiña unha insuficiencia tricuspidia masiva, dous componentes, por dilatación do anel, tamén inducida polo marcapaso que cruzaba polo centro da válvula, pero estaba anclado a nivel septal moi basal para a estimulación fisiolóxica. Como veis aquí se ve moi ben o TAC, enséñanos onde estaba implantado, estaba moi basal, a escasos milímetros do hinge point, do anel, e claro, aí ten que ir colocada a prótese, non hai outra forma de colocala, co que neste caso existe un risco moi alto de dislocar o electrodo e tamén de que poda mal funcionar o electrodo despois do implante da prótese. O que neste caso está aquí Joao, que estuvo comigo no implante, o máis importante foi abrir as anclas da prótese o máis altas posibles para evitar non abrilas no ventrículo, que logo poidamos traernos hacia arriba o cable de marcapasos, co que empezamos bastante altos, como veis aquí. Aquí estamos na fase de expansión ventricular. Aquí veis, axudámonos do eco intracardíaco. O principal era intentar chegar ao hitch point, onde temos que colocar a prótese nesta fase ventricular, non esperar a que a prótese seña máis grande, porque podíamos ter a dificultade de desplazar o electrodo e mover o electrodo, con que fomos moi arriba xa desde un principio para estar no hinge point neste momento e evitar o deslocamento do cable de marcapasos. Con lo cual, aquí vemos como estamos bastante arriba na primeira fase da expansión. Esta é a liberación final da prótese, que foi moi ben, non houve ningún problema. E fijaros como o cable de marcapasos non houve un paravalvular leak, que podía ser outro problema. E fijaros como o cable de marcapasos, como se ve na imaxe da dereita, na imaxe da radiografía, pois queda entre as dúas anclas e queda salvado aí o paciente. O bon deste paciente que dependía de marcapasos, e encima era unha estimulación fisiológica. Se temos un problema co cable de marcapasos, co electrodo, pois probablemente o paciente iba a empeorar clínicamente, iba a ir a peor, porque realmente tiña unha estimulación fisiológica, era o máis correcto. E encima, por suerte, non houve un aumento dos umbrales do marcapaso despois do implante. Outro tema importante é cando temos unha insuficiencia despois de facer unha reparación, como este caso. Este é un paciente que tiña unha IT torrencial bastante importante, un anel moi grande, 177 milímetros, Neste caso, a primeira intención foi realizar, cando se podía, facer cardiován, implantar un cardiován, e ficaros como pasou dunha insuficiencia tricuspidia torrencial a unha insuficiencia tricuspidia moderada, pero todavía tiña bastante insuficiencia, e o que logramos despois do cardiován foi reducir o anel un 12%. Pasamos de 177 a 157 milímetros e pasou de non ser posible implantar un EVOC a realmente ser un paciente que xa era candidato a implantar EVOC. Con lo cual, aquí isto foi o que fixemos, implantar un EVOC. Realmente, cando hai un cardiován, implantar un EVOC é moi sencillo. O único que temos que ter en conta é que, cando implantamos o cardiován, habitualmente pasa isto. Se o cardiován, como tira bastante do anel, do diámetro anteroposterior, pois suelen ser aneles que son moi elípticos. E, claro, tamén temos unhas estructuras metálicas que son as anclas do cardiován que poden impedir que suba totalmente a válvula hacia arriba, pero é moi raro, é un procedimento bastante simple implantar unha prótese EVOC dentro dun cardiován. E logo tamén temos o tema do TTIR, que bueno, un 5% dos casos pode fallar. Aquí temos un paciente con IT moi severa despois de implantar 3 clips. Este é un caso que me permitiu enseñar o Dr. Luis Lombela, que é moi didáctico de como tratar este tipo de pacientes. O primeiro que temos que ter en consideración é que, claro, cando temos varios dispositivos a nivel do anel, a nivel dos folletos, é ter espacio suficiente para meter a válvula, para meter EVOC. Lógicamente, neste caso, como veis aquí, pues, había un espacio, temos que ter al menos 3 centímetros, 30 milímetros, para poder pasar a prótese. En este caso, este dispositivo que está en medio, pues, evitaría un espacio pequeno. Para que isto funcione e para poder colocar unha prótese, temos que quitar este dispositivo que está en medio, este terceiro dispositivo, que o procedimento máis lógico era realizar unha Esta, unha electrocirurxía. En este caso foi utilizar, como explicou Manuel antes, utilizar dous catéteres e intentar facer a laceración, de quitar este dispositivo, facer a laceración do velo anterior para que os tres dispositivos quedasen a nivel setar e ter espacio suficiente para meter a prótese. Isto foi o que se fixo. Aquí veis que moitas veces é complicado facer, temos un catéter con un lazo, outro catéter con a guía de angioplastia, temos que cazar e externalizar a guía de angioplastia para logo poder facer a electrocirurxía. Neste caso, a veces é moi complicado facer o SNER no ventrículo dereito, neste caso fixose na pulmonar, que a veces é máis simple que no ventrículo dereito. Ao final, xa temos utilizando dous microcatéteres con fine cross e utilizando a guía Stato en V, como se fai habitualmente para estes procedimentos, se fixo a laceración do velo anterior pola parte septal. É moi importante, como veis aquí, que seña a parte lateral, que non seña a parte septal, que seña a parte lateral do folleto o que facemos a laceración. En este caso xa vemos como o dispositivo xa queda libre, está moi móvel e se pode implantar sin problemas a prótese EVOC. Fijaros como quedan os 3 clips dentro da válvula e a válvula puidose elevar a nivel do anel con moi bo resultado. Outro caso que este fixen fai pouco tempo é cando planteamos facer procedimentos combinados, a veces TAVIs con tricúspide. O problema de TAVI con tricúspide é o risco que existe de dañar o sistema de conducción. Neste caso, empezamos pola válvula aórtica, puxemos unha SAPIEN en posición aórtica o máis alto posible para evitar bloqueo de rama izquierda, que é o bloqueo de rama izquierda máis frecuente, e despois implantamos un EVOC, pero fijaros que nas poucas horas o paciente pasou de facer bloqueo da rama dereita, bloqueo da rama izquierda, e despois ao final fixo unha fricción auricular lenta e ao final houve que acabar nun micra. Co que, cando atacamos o sistema de conducción pola dereita, pola esquerda, por todos os lados, ao final, lógicamente, acabamos por dañalo. Co que, temos que ter en cuenta este tipo de riesgo. Na EVOC, o riesgo de marcapasos está en torno a un 15%, e tamén temos que ter en cuenta a hora de monitorizar estes pacientes, como este caso que describimos fai pouco tempo, que o trastorno da condución pode ocurrir incluso hasta 7-10 días despois do implante da prótese. E nada máis, estas son as conclusións e os casos que fun enseñando. Nada máis, moito obrigado.
Muito obrigado. Então temos pouco tempo, mas queríamos dar a oportunidade do painel poder realizar umas 4 pequenos comentários ou 4 breves questões, e por isso desafiava já o Luís para o primeiro comentário.
Obrigado. Parabéns a todos. Excelente. Estou aqui para aprender. E caladinho porque sou o único, portanto, não posso falar muito alto. Tinha questões fáceis e depois ignorância própria para Luís Puga. Há algum papel na ressonância na tua checklist prévia? E depois, para quem quiser responder, as válvulas que têm degeneração precoce, em que se aumenta a anticoagulação, qual é o mecanismo da disfunção tão precoce e se a anticoagulação é suficiente e o que se faz depois? Quem quiser responder, são as duas perguntas que eu tenho. Obrigado.
Então, se fosse possível, eu ia pedir ao Luís que respondesse a
Sim, sobre a ressonância, rapidamente. A ressonância é o gold standard da avaliação do ventrículo direito, mas com TACs topo de gama conseguimos ter uma resolução espacial e inclusive temporal muito boa. Também é possível fazer alguma caracterização tecidular por TAC, embora é mais difícil e usa-se menos. Eu diria que um TAC de boa qualidade que substitui a ressonância neste aspecto.
E a degeneração?
É muito complicado falar de degeneración da prótese porque non temos tempo suficiente como para ter un follow-up. O importante era, como comentou Manuel, nosotros facemos un TAC de seguimento ao mes e ao ano para ver como están os folletos e como está entotalizada a prótese. E vemos que en algún caso existe no halt, existe como un engrosamento dos folletos, que iso pode ser o signo inicial e precoz dunha degeneración futura. Pero falar ahora mismo dunha prótese degenerada cando levamos 1 ou 2 anos ou 3 anos implantando é moi precoz, todavía non sabemos a durabilidade, pero probablemente ao falar do lado dereito, alto risco de trombose, probablemente seña como as quirúrxicas, ao fin e ao cabo son próteses que non solamente polo diseño que teñan, senón que está no lado dereito, o risco de trombose é moito maior.
Claro, obrigado. Então, Joana, desafiava-te um breve comentário ou questão.
Se calhar eu colocaria aqui duas rápidas questões. Por um lado, e como nós vimos aqui hoje, primeiro cumprimentar-vos, foram ótimas apresentações, muito didáticas, também aprendi muito, mas gostava de saber a vossa opinião, porque como nós vimos aqui, efetivamente, a má janela acústica pode ser uma limitação, aliás, é uma limitação na intervenção percutânea da tricúspide, mas com o desenvolvimento das TACs, com menos radiação, mais rápidas, e particularmente durante o procedimento com a ecocardiografia intracardíaca e com o desenvolvimento das sondas, com possibilidade de 3D, se neste momento, na vossa experiência, uma má janela em transesofágico vos exclui este doente de um procedimento. E depois, de um ponto de vista mais clínico, não sei qual é que é a vossa percepção, mas a sensação que eu tenho, ou seja, nós olhamos para as guidelines no tratamento da regurgitação tricúspide e aparecem os sintomas. E a sensação que eu tenho é que às vezes os sintomas já aparecem numa fase um bocadinho tardia. E nós às vezes temos doentes que têm regurgitações muito importantes no ecocardiograma. E qual é que é a vossa experiência? O que é que costumam fazer? Seguem estes doentes mais atempadamente? Referenciam-nos logo mesmo numa fase em que estão muito pouco sintomáticos? Gostava de saber a vossa opinião.
Obrigado, Joana. Se calhar posso começar. Para nós, a má janela, antigamente era a questão da má janela transgástrica, em que era logo uma exclusão e é logo um glide superior. Nós agora temos a vantagem, temos de trabalhar também com os planos MPR em esofágico e aí já permite mitigar um bocadinho dessa limitação. Nós agora começámos também com o ICE tridimensional. Devo dizer que também não é a solução, não é um one-stop shop de todo. Vamos precisar sempre do ETE. Basicamente, os casos que nós fizemos, que ainda foram poucos, tivemos sempre a trocar entre os dois softwares para fazer o grasping de folhetos. De facto, vê-se muito bem com a ICE 3D, mas depois, por exemplo, para ver a orientação do dispositivo, vê-se muito melhor no transgástrico ou nos MPR com o transesofágico, mas sem dúvida nenhuma que nos veio melhorar um bocadinho e neste momento temos esses casos finalizados, não excluímos todo, mas propomos e com a ICE 3D temos conseguido tratar esses doentes também. Temos tido agora alguns casos de imagem particularmente difícil e com o apoio da Ana Botelho e com a equipa do ICE 3D temos conseguido tratar. Em relação a essa segunda questão, depois também pode outra pessoa comentar, mas no meu ponto de vista, quando um doente já tem uma insuficiência tricúspide grave ou graus superiores, mesmo que não seja muito sintomático, no meu ver, se for candidato a TIR, eu proponho isso ao doente. De facto, é extremamente seguro, cada vez temos mais eficácia com toda esta tecnologia e eu pessoalmente acredito que muitas vezes o doente está sintomático e não percebe, nós até vemos isso na estenose aórtica, tem um impacto muito maior com sintomas e mortalidade e, portanto, aqui provavelmente a história será a mesma. Se o doente não for candidato a TIR, aí eu pessoalmente já sou um bocadinho mais conservador por causa da segurança do procedimento. Não sei se...
Sí, a miña opinión é moi parecida. É verdad que en algún caso tamén tiño utilizado a trick valve, que a prótese picaba, casos moi seleccionados, onde hai que ter en consideración que moito a hemodinámica do paciente, que non teña hipertensión pulmonar, pero bueno, a verdad que cando está moi estadio avanzado, probablemente temos que, non sabemos ahora mismo que cando un procedimento é fútil ou non, entonces é complicado tomar a decisión, porque nosotros que somos hemodinamistas pues sempre queremos tratar, pero é verdad que moitas veces probablemente empeoramos clínicamente o paciente, porque cando son moi severas, probablemente a mellor opción é a reparaxeado porque é o menos complexo que onde menos problemas hai no ventrículo dereito.
Obrigado. Eduardo, por favor.
Um comentário. Eu não estou rendido ainda absolutamente ao sucesso a longo prazo, e vou repetir, a longo prazo, das próteses valvulares tricúspides. Isto porque a história da cirurgia provou-nos que as próteses cirúrgicas na tricúspide não vingaram. Eu tenho uma esperança, é que ocorra na tricúspide aquilo que ocorre nas tábios. Nós sabemos que sempre que abandonamos o acesso femoral, a tábio perde o edge que tem sobre a cirurgia. Isto é, puncionar o tórax não faz bem ao doente. E a minha esperança é que a longo prazo as próteses percutâneas valvulares tricúspides provem pelo simples facto de não perfurarmos o tórax. Estou mais convencido nos edge to edge. Há agora uma nova classe que eu acho que vai surgir, que são os spacers, mas a longo prazo eu temo que não estamos a considerar as lições que temos a longo prazo pela intervenção valvular.
Obrigado, Eduardo. Rui, por favor.
Obrigado, Adamastor, por me teres facilitado a vida. Eu estava aqui a olhar para estas apresentações que foram excelentes e muito pedagógicas e estava a pensar o que é que faz, o que é que nos limita. Neste momento temos a Evoque no mercado há 1 ou 2 anos, temos outras válvulas a chegar e começamos a ter um conjunto de dispositivos que competem claramente com o edge-to-edge. E o que é que faz com que nós não queiramos implantar uma válvula que reduza a ressuscitação tricúspide a zero? Em primeiro lugar, faz quando o VD não pode tolerar isso. Mas aquilo que nos preocupa muito é também, por exemplo, a anticoagulação e o risco hemorrágico. Mas 90% destes doentes têm uma causa funcional aterogénica, portanto, a anticoagulação já está a bordo da maior parte deles. Portanto, essa questão não é uma questão relevante, não é questão médica. Tem muito mais a ver com outros fatores, como custo, como imagem e como outras coisas. Portanto, o que eu estou a ver, e eu gostava de ouvir a vossa opinião, particularmente do Ângelo, que é a pessoa que tem mais experiência aqui com as válvulas tricúspides percutâneas, eu neste momento vejo que nós, nos doentes que antes estavam no risco, na complexidade intermédia do edge-to-edge, neste momento vão resvalar para as válvulas percutâneas em vez de resvalarem para o edge-to-edge. Porquê? Vamos passar a fazer edge-to-edge quando temos a certeza que temos bons resultados. E quando estamos na dúvidas, vamos virar para o outro lado, a não ser que haja um risco hemorrágico, a não ser que o VD não tolere, a não ser que a imagem seja uma porcaria.
A verdade que é pregunta do millón, porque eu fago-me esta pregunta todos os días. É complicado, é complicado. En primeiro lugar, de punto de vista do paciente e do clínico, o mellor é a reparación, sin duda. Por qué? Porque o ventrículo dereito non se daña, queda unha IT residual sempre, o paciente pode ser dado de alta prácticamente o día seguinte, suelen mellorar, e sobre todo que ahora tamén o procedimento mellorou moito, ahora somos moitos casos capaces de conseguir unha IT leve ou cero, en moitos casos. Sobre todo, co que se tú consideras que o primeiro paso é reparar sempre. En segundo lugar, cando ves unha IT torrencial, un gap gigante, pois entonces non te queda máis remedio que facer a sustitución valvular. Eu que digo moitas veces, que teño aquí compañeros de Edwards, que o tema é que é complexo, pero podemos facer moi sencillo. Tú podes ir pensando nun procedimento que vas a hacer vou reparar a válvula. Pero moitas veces ves que no primer grasping é imposible. Estás no anterior e non és capaz de reducir nada, pos un dispositivo, non o liberas porque aí te empeora. Nestos casos había que ter a opción de cambiar no mismo procedimento e realizar unha sustitución valvular. O sea, que vale, ahora mesmo está moi complexo facer o repair. Pois parar, e dicir, preparar, dá má válvula a prótese que poña a prótese, porque en moitos casos é así. Moitos temos que parar, en moitos casos, dispositivos, bueno, ao largo plazo sabes que os dispositivos van a fallar, porque estamos facendo casos moi complexos. É unha cousa cando diagnosticas o paciente e tes un TI inicial, pero cando faz o procedimento as cousas cambian moitísimo. Tú pasas de ter moi boa imaxe ao principio e cando faz o procedimento empeora, e non ves os folletos, e todo é complexo. É complicado. Eu penso que tiene que ser unha cosa bastante máis flexible, poder, incluso sobre a marcha, poder cambiar e poder dicir, mira, pois ahora mesmo isto non é posible reparar e podo facer unha sustitución valvular.
Penso que temos agora que terminar esta sessão. Muito obrigada a todos os intervenientes, acho que a sessão foi excelente. Todos temos imensas perguntas ainda, felizmente vamos tendo algumas respostas, mas temos que passar agora para a sessão de abertura desta reunião. Obrigada a todos.
Bem-vindos a mais uma VaP-APIC. Vamos dar início à sessão de abertura e dou já a palavra aqui à doutora Cláudia Jorge, presidente da nossa reunião. Obrigada. Olá, muito boa tarde a todos. É definitivamente uma honra e é um prazer estar aqui a poder-vos dar-vos a todos as boas-vindas à VaP-APIC. Muito obrigada pela vossa presença. Sabemos que atualmente o tempo é algo muito importante, portanto terem decidido pegar em aproximadamente 2 dias e decidir que deviam utilizá-los para estar aqui a refletir sobre o estado da cardiologia de intervenção em Portugal, a partilhar as vossas experiências, a mostrar os vossos casos, é para nós muito, muito importante. A VaP-APIC foi criada essencialmente para isto, para ser um espaço de partilha, um espaço de discussão nesta área de cardiologia que podemos dizer seguramente que foi aquela que cresceu a uma velocidade seguramente avassaladora. Atualmente realizamos nos nossos laboratórios de hemodinâmica procedimentos que há uns anos atrás consideraríamos extremamente complexos. Hoje são apenas procedimentos rotineiros e diários que decorrem conjuntamente com as nossas equipas. E não estou simplesmente a falar sobre as TAVIs, também estou a falar da intervenção tricúspide, a intervenção mitral e, nomeadamente na tricúspide, como acabámos de ver, que atualmente vai muito além da reparação bordo a bordo. E chegamos mesmo a desafiar-nos, fazemos cada vez casos mais complexos, a decisão da terapêutica do doente é baseada caso a caso, as estratégias são extremamente difíceis, não basta apenas sermos cardiologistas de intervenção extremamente competentes do ponto de vista técnicos, Precisamos seguramente de bons clínicos cardiologistas, precisamos de conhecer a anatomia complexa, a imagem é fundamental. E é exatamente por causa dessa mesma razão que não conseguimos, acima de tudo, tratar um doente sozinho, porque nós trabalhamos em equipa, que quisemos uma faculty multidisciplinar. Contamos com uma faculty de 66 colegas e a eles que quero dizer muito obrigada, porque sem eles esta reunião não seria de todo possível. Contamos com cardiologistas de intervenção, cardiologistas clínicos, cardiologistas de imagens, cirurgiões e com uma equipa extremamente diferenciada de enfermeiros e de técnicos cardiopneumologistas. Muito obrigada a todos para poderem, em conjunto, tratarmos os nossos doentes. Óbvio que tenho também uma palavra de estima e de agradecimento à nossa Faculty Internacional, em que podemos ouvir uma excelente palestra por parte do Dr. Ángel Sánchez, que veio de Madrid ter connosco. Seguidamente ouviremos falar o Dr. Didier Chiché, que veio de Toulouse, o Dr. Arif Kokar, de Copenhaga, o Dr. José Parada, que também veio de Madrid, e seguramente temos também aqui uma grande colaboração com os colegas do CS Madrid, na presença do Dr. Luís Asmarat, da Dra. Gabriela Tirado e do Dr. Júlio Eckhart. Mas o dia não está a começar agora. O dia já começou hoje e começou bem cedo com os nossos cursos. Tivemos cursos essencialmente práticos, de hands-on, em que o formato essencialmente foi apostar na partilha e no contributo de casos numa discussão entre pares, entre colegas. E como tal, podemos então formar novas pessoas em acessos femoral de grande calibre e complicações dedicados à imagem transesofágica para o tratamento bordo a bordo e também para otimizar o percurso dos nossos doentes de TAVI e ainda cursos mais diferenciados como o RIDU de TAVI em TAVI. E foi isto exatamente que decorreu durante toda a nossa manhã, uma partilha de experiência, uma partilha de conhecimento para sempre contribuir para a evolução da cardiologia de intervenção. Como o nosso lema e o lema da VaP-APIC é exatamente esta, é a experiência real, é a prática, é aquilo que fazemos no nosso dia-a-dia, contamos com 3 lives in the box. Um deles veio de Vila Nova de Gaia para a intervenção tricúspide, seguir-se-á o centro do país com o ZUC com a intervenção mitral e o sul representado pelo Hospital de Santa Maria para uma intervenção em TAVI. Mas como nós nos desafiamos e queremos cada vez mais e tratamos de casos cada vez mais complexos, então desafiámos em colaboração os colegas do CIS Madrid e desenvolvemos aqui um grande tema. Então, por que é que não nos chamamos mesmo essa mesma sessão THV Mission Impossible? E é o que vamos, de facto, poder assistir com estes casos desafiantes e completamente fora da caixa, e eu espero que esteja uma sala tão repleta ou ainda mais como está neste momento. Obviamente que não podemos deixar de agradecer toda a colaboração da equipa dos técnicos e de enfermeiros que decorrerá daqui a pouco simultaneamente com a Breakout Room, com temas extremamente interessantes que vão desde a TAVI ao tratamento da válvula tricúspide e da válvula pulmonar. Esta reunião pauta também por algumas inovações, nomeadamente estamos a ter transmissão live no canal da APIC no YouTube e pela primeira vez destacamos a presença dos Best Awards em Cardiologia de Intervenção Estrutural, cujo prémio será a permitir a presença no London Valves de 2026. Obviamente, quando falamos de uma reunião desta envergadura, muito se passa para permitir que hoje possamos estar todos aqui. Portanto, a mim cabe meramente poder agradecer a todo o comitê científico, a toda a equipa de apoio que vai desde a estrutura da APIC à Meeting Point e, obviamente, aos nossos parceiros da indústria, sem os quais isto não poderia ser possível. Muito obrigada. E, acima de tudo, desejar que aproveitem esta mesma reunião, partilhem, estejam presentes, façam perguntas, digam que concordam, essencialmente digam que discordam, que faria de uma forma diferente, interajam. É para isto que esta reunião está aqui hoje e espero que este objetivo seja atingido ao fim de 2 dias, que cumpram, seja cientificamente interessante, que façam um excelente networking, mas que acima de tudo, se ao fim destes mesmos 10 dias seja uma reunião entre amigos que têm um objetivo comum, que é o amor pela cardiologia de intervenção. Muito obrigada a todos.
Muito obrigada, Cláudia. Eu vou só dizer umas palavras aqui. Realmente a intervenção valvular em Portugal tem tido, e na Europa tem tido um crescimento exponencial. Já há alguns anos, passam não assim tantos, desde que a primeira TAVI foi implantada em Portugal em 2017, e a que se seguiu depois a mitral e a tricúspide, e desde então temos visto um crescimento exponencial no tratamento destes doentes que nós não tínhamos solução para oferecer há poucos anos atrás. E queria partilhar com vocês uma preocupação da APIC, desde que nós aqui assumimos a direção, que são as listas de espera dos procedimentos percutâneos, mas principalmente dos procedimentos valvulares, e neste caso da TAVI, que acho que é a lista de espera mais preeminente em Portugal, e cuja maior lista é aqui na Zona Centro, precisamente, e nós temos tentado chamar a atenção da tutela para este assunto, desde que assumimos a direção, e eu digo tentado porque é mesmo muito difícil, mas queria partilhar com vocês esta preocupação, que acho que já todos têm conhecimento. A última vez que nós falámos com a tutela sobre este assunto foi precisamente há uma semana, em que tivemos uma reunião com o Secretário de Estado de Gestão e Saúde e com uma das representantes da ACSS, e fizemos a nossa proposta para todos os procedimentos percutâneos, e nomeadamente as TAVIs, serem incluídos no novo sistema de gestão de doentes de inscritos em lista de espera. Até agora não temos feedback, mas temos alguma esperança que isto venha a acontecer. Aproveitando que estamos na VaP-APIC, uma vez que isto é uma reunião de intervenção estrutural, valvular, aproveito para anunciar o curso de intervenção estrutural que vai ocorrer em Milão e que é organizado pela Esta e pela APCI no dia 29 e no dia 30 de abril. Se estiverem interessados, principalmente os mais novos, inscrevam-se, porque isto vem na sequência do core currículo que foi publicado da APCI, a intervenção estrutural, e acho que todos os jovens que estejam interessados nesta área devem fazer. E termino por anunciar oficialmente a abertura das bolsas para projetos de investigação na APIC. Nós vamos ter 3 grandes áreas de bolsas para projetos de investigação: a doença coronária, a intervenção valvular e a intervenção estrutural não valvular. Todos os pormenores podem ser encontrados no site da APIC a partir da próxima semana. Portanto, temos alguns critérios de inclusão que são bastante ambiciosos. Portanto, quem estiver interessado, eu convido-vos a visitarem o site da APIC e verem quais os critérios e também as métricas que nós pedimos para que possamos fazer boa investigação em Portugal. Temos financiamento, também lá vai estar descrito, e peço-vos para realmente consultarem o site da APIC para verem os critérios das bolsas de investigação. Resta-me agradecer, mais uma vez, a todos, à Cláudia, à Comissão Organizadora, à doutora Cristina por estar aqui connosco, a todos os que se deslocaram até aqui e que aceitaram discutir e falar e ser formadores, à Ana Domingues e, claro, à Patrícia pelo trabalho excepcional que fazem todos os dias, à Meeting Point, claro, pela organização, e, claro, aos nossos parceiros da indústria. Sem eles não poderíamos estar aqui. Obrigada.
Bom, cabe-me a mim a última palavra, e eu gostava, obviamente, de agradecer em primeiro lugar a oportunidade de aqui estar, cumprimentar a Cláudia pelo excelente trabalho realizado na organização deste evento, juntamente, obviamente, com uma enorme comissão organizadora, e a Joana por aquilo que tem feito também no seguimento de outros grandes presidentes da APIC, daquilo que tem mostrado que é possível fazer para tentarmos melhorar as coisas dentro da área da cardiologia de intervenção. Dizer-vos que a mim é com grande honra que devo dizer que em certa forma vim nos passos do professor Helder Pereira, que me antecedeu na Sociedade Portuguesa de Cardiologia como presidente e que me mostrou como é importante que nós tenhamos cardiologistas de intervenção a mostrarem ao resto da cardiologia o papel relevante que têm, mas a forma como também sabem comunicar com os outros. E, portanto, esta não é uma disciplina isolada da cardiologia, esta é uma disciplina essencial que tem que comunicar com todas as outras, porque no final nós temos que tratar o melhor possível as pessoas que temos à nossa frente. E não há dúvida que muito daquilo que nós hoje em dia conseguimos entregar vem desta evolução que a cardiologia de intervenção teve.
E é preciso também compreendermos que muitas dos grandes desafios e destas coisas que aqui falamos, que felizmente estão a avançar em larga medida, nomeadamente no que diz respeito à investigação, nós podemos ter mais apoio para a investigação, bolsas de investigação, cursos de formação, também é muito importante percebermos que vamos precisar necessariamente de ter melhor capacidade de referenciar estas pessoas. Quando nós aqui estamos a falar de listas de espera, que a todos nos preocupa e que infelizmente vieram para as notícias pelos piores motivos, provavelmente um motivo muito importante para se falar, mas não da forma como se falou, a verdade é que nós temos aqui desafios enormes a fazer. E isso prende-se não só com a definição do que é efetivamente um centro de referência, mas também o que é que são as redes de referenciação. Que não são coisas iguais, são coisas diferentes, mas para as quais nós vamos ter que encontrar respostas. Porque nós não podemos ter um país a duas velocidades e haver pessoas que têm acesso a determinados tratamentos e outras que não têm acesso. Até porque os recursos têm que ser de forma mais ou menos equitativa distribuídos. Portanto, eu diria que nós temos neste momento um problema para resolver, indiscutivelmente, mas também temos uma oportunidade. Por um lado, porque estamos a falar de um momento em que nós temos um plano europeu pela primeira vez, cardiovascular e saúde, e, portanto, o Safe Hearts Plan tem que ser aproveitado. É um programa para o qual o nosso governo, os nossos decisores políticos têm que acordar. Isto tem sido falado em toda a Europa e não há, neste momento, ainda nenhum movimento concreto em Portugal, para além daquele que tem sido feito pelas próprias instituições que estão ligadas à cardiologia, nomeadamente as sociedades científicas. Não tem havido um verdadeiro entendimento daquilo que vai ser a oportunidade deste plano, mas nós vamos ter necessariamente que começar a juntar-nos e a discutir o que é que nós queremos desenhar para o futuro da cardiologia em Portugal. E é com esse desenho que nós devemos efetivamente aproximar-nos dos decisores políticos e aproximar-nos da Europa para podermos ser capazes de fazer mais e melhor. Portanto, eu acho que aqui nós temos que deixar uma nota muito positiva de que tudo aquilo que nós fizemos foi excepcional, mas eu tenho a certeza que nós temos no futuro muito mais para fazer e se o fizermos em conjunto vamos ter muito mais sucesso. Obrigada.
Muito obrigada, professora Cristina Gavida, por as palavras. Muito obrigada, Joana. E, como disse há pouco, aproveitem a reunião é para vocês. E agora temos o nosso coffee break. Obrigada.
but the cases that you...
Lifetime.
You're...
So welcome to this session about TAVI strategies, pitfalls, and lifetime management. I welcome our panel. I welcome Dr. Manuel Almeida for co-chairing this session with me. And let's start with Didier Tchétché. I think he excuses any presentations, an interventional cardiologist from Toulouse, from Clinique Pasteur, and coordinator of the structural program. Welcome, and we'll start with some redo TAVI cases, right?
Yeah. So, boa tarde. É prazer estar aqui. So, okay, so I just prepared a couple of cases, and we should take the opportunity of being this group of physicians just to discuss about these cases, so you can interrupt whenever you want. Let's try to get it as interactive as possible so as we exchange our experiences. So the first case that I wanted to share with you is a case that I treated, a lady that I treated 2 years ago. At that time, she was 80 years old, symptomatic with a high pro-BNP, and not overweight, so more or less the type of patient that you would find in Portugal, I guess. A whole lady, not overweight. So this is the index procedure. So it was now 10 years ago. She was treated with a Sapien device, Sapien 3 device. The annulus at that time was 21.7, close to 22 millimeters. And so we decided to put a 23 device. And this is what we got at the end of the procedure, mild regurgitation that disappeared during the follow-up. And 7 years afterwards, she had a PCI of the left main. So we were quite satisfied, and she came back 8 years afterward with stenotic degenerescence of that bioprosthesis. The ECG was okay. And the LVEF was still preserved at that time, and you can nicely highlight and understand the mechanism, the mode of failure. That was a stenosis with a mean gradient of 45, a peak velocity of 4, and a normal, more or less normal systolic pulmonary arterial pressure, given the age of the patient, nothing noticeable for the medication. It's interesting because she had some SGLT2 inhibitors already. So this is maybe the most important aspect of the management of patients with a failed bioprosthesis is the CT scan. So we don't have the index procedure CT scan, but the annulus was 21.7, and we put a 23 millimeter device inside, and you can see what is the diameter that we get. At the time the device fails, it's not even 20, it was 19.4. with a quite circular shape of the Sapien 3, but definitely an under-expansion, and that's something that is quite systematic when we go for assessment of failed bioprosthesis, that systematic under-expansion. We see that. So is there any kind of recoil, remodeling within the anatomy of the patients? We don't really know. So this is what we have, 19.4. And as usual, we try to understand what is the risk of coronary obstruction for the patients. Here we have a device that is not fully expanded. So as a consequence, the foreshortening is not super important. So the device is quite tall, extends above the seminotubular junction. But luckily, when we do the valve to coronary distance on the right side, it's above 4, so it's okay. But the main issue is on the left side with a valve to coronary distance of only 2. So maybe I can pause there for a couple of seconds, minutes if you want, and we can have a bit of a discussion about this case. So what would you do in terms of type of device and technical aspects for this patient? So.
So,
Can
would you like to
So
comment?
anyone wants to jump in?
It's quite impressive that it took so long to degenerate, because it's a very small valve, so it's the kind of anatomy that nowadays we try to use a supraannular design to have a better gradient, hoping for less degeneration. So it was like 8 years?
8 years afterwards, yeah. So quite late, yeah.
To see the VTC, it would be, if we could see, I don't know if you have also the image from the ostium of the coronaries to the valve, because it's difficult to
for
understand.
the right it was fine. So, but mainly the risk was for the left, yeah. So would you go for a balloon expandable valve here or self-expanding?
Conceptually, I would prefer inside a balloon expandable, self-expandable, supraannular. The problem here is the risk of coronary obstruction, of course. The PCI was performed after.
Yeah, like
so
7 years afterwards.
You got a good access to the coronaries despite the sapien. I'm looking forward to see how did you.
So self-expanding, but my question, if you go for a self-expanding, the inner diameter is only 19.4. So would you, it's close to 20. Would you prefer a 23 self-expanding supraannular or a 26? That's another question, because we've tackled the issue of hemodynamics. So if you want a better hemodynamics, maybe it's preferable to go with 26, but is it going to be suited for this anatomy?
We'll have to see the sinotubular junction and the diameter.
So integration of the sinotubular junction and the diameter.
And what about neo-skirt plane?
And the risk, the neo-skirt risk plane, so it was extending above the sinotubular junction, but the STJ was fine. It was really the distance to the left that was only 2 millimeters. On the right side, it was okay.
So probably you would have to do some leaflet modification, basilica or...
Basilica?
Yes.
Okay. Any other opinion? Rui? Dr. Teles?
So as far as I understand, the VTC to the left main is 2 millimeters. Is that so?
Yeah, 2.
But you have the height till the left main is 10 millimeters. So you have two options probably. One is to use a balloon expandable device and you have to go lower with it. Maybe there's a question regarding the residual gradients, but it's possible. I think you can. It's precise, and you can select that option. And of course, in that case, eventually, since you already had performed the PCI before, you can protect with a wire, and just that's one option. If you select a self-expandable valve, you have different options, either NABIT or core valve. But in those cases, I'm not sure that the way to protect coronaries is the same, because probably the stent frame will go up and will be in front of the. And in those cases, I would prefer to eventually to perform basilica or that sort of approach. But anyway, these cases are never easy to perform, and we are always a little bit worried with the final result during the intervention. Thanks for sharing.
There is a, please.
I guess it's a sapien, so commercial alignment, which could be anything, and that might sway you to a valve strategy or positioning, if you can cut the leaflets or not.
So it's a very nice discussion, because I guess we've addressed, most of the concerns, the hemodynamics with the under-expansion, so that may favor a self-expanding platform, the risk of obstruction of the left main, with the need for leaflet modification or at least some kind of protection. So the coronary issue has to be taken into consideration, and this is truly one of the main challenges of redo procedures. So let me drive you through the case. So nothing special at the level of the peripheral vascular disease, peripheral vasculature, and so we decided to go for a redo TAVI. So cerebral protection, As usual, we use it for all our reduced AV cases, valve in valve, complex valve in valve cases, bicuspid cases. And as it was proposed, we decided to go for a basilica only on the left side. The right wasn't at risk according to our opinion, so we moved only with a basilica of the left leaflet. The commissural alignment was favorable enough just to allow for a safe basilica, so we went for that. Slicing the left leaflet, I guess here the combo was Emplatz left 2 7 French, Navicross inside, microcatheter inside, Astato, and multipurpose 7 French through the valve. So it wasn't too difficult to get the cut, and we had a kind of massive regurgitation afterwards, telling us that and confirmed by the TOE, the opening of the leaflet was fine. And then as there was a regurgitation, we did pace the patient from very early within the procedure just to stabilize the hemodynamics. And then we went for a 26 Evolut FX at that time. It wasn't the FX Plus. Evolut FX targeting inflow to inflow overlap between devices. And it was quite easy to obtain something that was accurate, no major obvious obstruction of the left main, and that was reassuring. And after post-dilatation, this was the outcome that we obtained for that patient. So it was exactly the type of discussion that we had, and we went through a step-by-step assessment of that. And this is the post-implant CT scan. You can appreciate how crowded the environment is for that lady, 80 years old. So maybe in 5-6 years, there will be the issue of the third procedure. So no one knows what it's going to be, but we will have a challenge at that time. So in terms of frequency, it's not that frequent yet. For us, it's less than 1% of our cases, so it's not a big number of cases. But we do anticipate that it's going to be more frequent, like in 2 years, in the 2 years time frame, we're going to do more and more redo procedures. So we all need to learn how to perform these procedures because it's going to be quite common in the future. Second case, and this is a patient that is quite similar, that we treated for London valve, so 79 years old female, symptomatic, sapien 3 that was implanted only 5 years ago. So the first case, it was 8 years. Here it was only 5 years in 2020, July 2020. And the annulus was more or less in the same range, 21.5. And this is the past medical history of the patient, as you can see on the slide. It's always important to compare what you had at baseline and what are the metrics that you get once the patient becomes symptomatic, the device fails. And you can see that there was immediately after the procedure, the EOA wasn't that large. It was a 23, and we only had 1.55 centimeters square. So maybe this was a kind of indication of a potential early failure, because to me 5 years is not acceptable with a peak velocity close to 2 meters per second and a mean gradient averaging 15. So already signals of potential early failure of the device. And this lady became symptomatic with, on the right part of the slide, a stenosis, stenotic degenerescence of the bioprosthesis once again. Moderate aortic regurgitation. So this is, here we have a more contemporary assessment of the device, and you can see first we have a commissural alignment that is not good. It's a very poor commissural alignment. Second, we have something that is quite circular with a mean diameter around 20. The annulus was once again 21.5, and we only have 20 for the device. So once again, that systematic under-expansion of the devices. We had that leaflet thrombosis or fibrotic, or I don't know what it is exactly, thickening of the leaflets. And even the top frame of the device wasn't fully expanded, 20. for a 23 millimeter device, which was quite surprising. In terms of the risk of coronary obstruction, virtually negligible, because the stent frame ends up just below the coronary osteums, and the distance between the valve and the coronary was acceptable. So peripheral vasculature, nothing special. So we decided to go once again for a redo procedure. It's exactly the same discussion. We went for a self-expanding valve without any coronary treatment because the risk of coronary obstruction was minimal. So we did put a sentinel device as usual. And this is the reference angiogram, and it's quite striking. Two major informations here. The first one is, once again, we have a device that is elongated. And it tells us that if we use, that's why I'm not a big fan of the S3, -1, -2, plus. It doesn't really make sense, to my opinion, because we end up with devices that are not fully expanded, with some kind of pinwheeling or trauma to the leaflet. And here, given the size of the sinus of Valsalva, you can see how filled with material the sinuses are. We can't even see the sinuses. So potentially with a smaller device, 21.5 fully expanded, we would have got something with a better hemodynamics, better performance of the leaflets, and more enough space for the blood flow around the leaflets. And that's something that I'm considering more and more when I'm thinking about the index procedure. So regardless of that, we went for a pre-dilatation with a non-compliant balloon, and you can just watch the shape of the stent frame. It's expanding fully. So during the first procedure, there was a fear of any annular rupture, a risk of disruption of the overall sinus of Valsalva architecture. But here with the post-dilatation, we could further expand the index valve. And to my opinion, pre-dilatation should be the first step of a redo procedure. And if you compare on the right part of the slide, pre and post, this is what you get. You can see that the device is much more shorter and more expanded. So no major regurgitation and no issue at the level of the coronary arteries. And then we went once again for a self-expanding valve, aiming at inflow to inflow or slightly close to the inflow. Taking the time to make sure that we land the device exactly where we wanted. We used the 26 to maximize the hemodynamics for that lady. And then after that, we even once again went for a post-dilatation with a 22 non-compliant balloon, more aggressive, but respecting the size of the constrained portion of the evolute, just to avoid any issue with the leaflets. And this is the final result. And so it may look quite simple like that, but in fact, it's exactly the type of discussion that we had. We need to prepare, understand all the challenges, and prepare everything in advance. And this is the post-implant CT scan. Circularity, a very nice commissural alignment for that lady, a device that is large enough. You can compare pre and post, and definitely we were quite happy for this patient. So she was discharged quite a couple of days after the procedure. You can see the difference in terms of EOA, 1.55 for the first procedure, almost 2.3 for the redo procedure. So maybe we should have done better at the index procedure because we could achieve that during the redo. Very last, just an image rather than a case, because I have selected tall and short redo procedures, and I do believe that there are challenges when it comes to short and tall, particularly for the stability of the device when it comes to the expansion. So here it's a regular patient with a failed evolute platform, regurgitation, I guess, if I'm not mistaken, 29 evolute. And I wanted to focus on the deployment. You can see all the efforts that we tried to apply to get something that was perpendicular, pushing on the wire, keeping the stent of the sapien quite deep, just to target the node 5. But regardless of what you do, the device chooses where it's going to land because of the interaction of the balloon with the stent frame, of the stent with the stent, and it's a bit of a challenge. So you're going to see the expansion of the device, and it's true that we should take time to try to really target a perfect landing, but most of the time we are not. We don't choose. Look at the balloon. It starts to inflate and everything goes up. Even if you try to push on it, once you get that contact of the balloon with the stent frame, it lands wherever it wants. That's why all that philosophy, that bench testing, we're going to target node 4, 5, 6, it's theory. And then in practice, in real practice, it's a little bit different. Okay, thank you very much. I'm going to stop here.
Thank you very much for the cases. Let me just ask, do you see more under expansion with balloon expandable or with self-expandable? And how do you think we can avoid it? Because do you think you're being too conservative in pre-dilation or post-dilation? Because it's a discussion we should have. We are treating younger patients every day.
Yeah, definitely. I think you're right. That issue of under-expansion has become more and more important, particularly if we target younger patients. And we want to achieve circularity. And for balloon expandable valves, there is that trend of double tap. So you expand the balloon expandable valve, and then you use the same balloon just to reinflate to make sure that you get the maximum expansion of the device. So that's quite important. And we are doing the same type of work with self-expanding. It's a bit different with self-expanding because first we need to decide on the balloon diameter that we're going to use for post-deal. And second, there could be a price to pay in terms of embolization and so on. So we're still work in progress, but we should really work hard to get a circular device and full expansion.
So let's move forward the talk.
Okay.
On optimizing lifetime management of TAPI patients.
So in the same spirit, I'm going to maybe spend 10-15 minutes speaking about optimization of the lifetime management of our patients. And it's more important because we know that we are treating more patients, younger patients. These patients are going to live a long time, and so the need for a redo procedure is going to be super important. So these patients are going to require multiple treatments. So it's not a single shot. We need to think ahead in advance about what are the options, what the options are going to be once a patient comes back with a failure. So treating a patient is not only about putting a device in place, it's trying to optimize what is meaningful for the patient. It's trying to prevent coronary obstruction for sure, keep the door open for any further coronary cannulation, avoid annular rupture, avoid aortic regurgitation, avoid pacemaker, maximize the hemodynamics, and this goes through several items on the device, whether it be the open large cell feature of the device, a ceiling skirt, a short stem frame height, many aspects, but our techniques that we use during the procedure are going to impact the overall lifetime lifetime impact of our procedure on the patient. So we have different platforms. So you're going to meet platforms like that. New generation, at least newcomers, with large open cell design, a ceiling curve that is meant to mitigate paravalvular regurgitation, the open cell to keep the access to the coronary arteries, and what I like, a device that expands and is quite stable, at least for the inflow during the expansion. So knowing the device that we are using and applying the proper technique is going to be super important. What is crucial when it comes to integrating the lifetime management into for a single patient is understanding that the life expectancy of the patient has to be a clear and important central element for decision making. You've seen that slide. It's derived from the surgical work from our Swedish, our Nordic colleagues, and it's interesting. Everyone thinks that once if you are a low-risk patient, you are 70, you're going to live until 90, 95. It's not true. This may be true for the Japanese community, true. For our European community, you can see that 70 years old, bottom part of the slide, you only have 12 or 13 years of life expectancy remaining. So you could be treated with a single device or two devices, two procedures. So definitely this has an impact and may explain partly why the new ESC guidelines chose 70 years as a cutoff for TAVI. So we have now that type of algorithm. If the patient is super young, you're going to go into more complex procedures like a Ross procedure, a mechanical valve. Between 60 and 70, it's going to be a bioprosthesis. And we have now that option with the Start Young trial that is randomizing patients at any type of risk, 65 to 70 years old, between TAVI and surgery. If you are above 17 now, it's going to be a TAVI with a bioprosthesis, unless you have a very complex tricuspid anatomy and or a very complex bicuspid anatomy. So there is a trend that is going to come, I guess, in a couple of years to your country. But now in Europe, clearly the 70 years old has become a kind of standard, and the ESC guidelines are matching what we are doing, what we've been doing for a couple of years now. And this came from for those who are not that familiar with the literature, this came from the partner-free trial, low-risk trial, randomization of TAVI and surgery in low-risk patients, and you can see that at 7 years, the outcomes are exactly superimposed, overlapping between surgery and TAVI, and reinforces the message that with the TAVI platforms that we are using, the contemporary ones, the outcomes are quite impressive for our patients. And we had in the past a smaller cohort, very early iteration of the core valve, the self-expanding platform, TEE guidance, but even with that preliminary experience with a self-expanding valve, at 10 years, limited sample of patients, but superimposed overlapping outcomes, particularly survival between surgery and TAVI, 10 years. So definitely, once again, 70 years old or low-risk patients, 12 to 15 years of survival, 1 or 2 procedures could be enough. So it's all about the sequence, what we're going to choose for our patients. So I truly believe that the heart team is going to remain central, because for a given patient, we will need to select the first procedure wisely, because this is going to impact the rest of the sequence for the patient. We know from the literature that if we do TAVI first and the patient survives the device and requires another procedure and you go for surgery, it's going to be more complex. If you explant these TAVI devices, there is a higher likelihood for aortic root repair and a high mortality to pay. And there is one caveat to this study. These were inoperable or high-risk patients. So I don't know exactly what it is going to be for low-risk patients, but technically for the surgeons, it seems to be difficult. This is new, and this is something that we need to integrate. When we put stents within the aortic root, even if we don't see it, we say, okay, I'm going to use a large open cell design, and it's going to keep the access open to the coronary arteries. There is cell ingrowth, and if by a matter of bad chance, that cell ingrowth is just in front of, covering the cell in front of the coronary artery, this could be an issue, once again. So we are more and more learning about the pathophysiology and the mode of healing of these devices. So we need to integrate that. And for a given patient, it's not only about doing a TAVI or surgery, it's making sure that the first index procedure is going to keep the door open for the subsequent ones. What we also know is that hemodynamics seem to play a role in terms of quality of life and potentially survival for our patients. We've known that from the surgical literature. If you treat younger patients, low-risk patients, and you operate them and they get a severe patient prosthesis mismatch, small EOA, high gradients, these patients first are going to be impacted in terms of exercise capability, and second, they're going to die more. And this is from the surgical literature. So even though we don't have the same signals for TAVI, there is no reasons for which we wouldn't see the same thing. It may be only a matter of timing. If you watch the right part of the slide, in that super large meta-analysis, the curves in terms of mortality in between the patients without severe patient prosthesis mismatch and those with a severe patient prosthesis mismatch, they tend to diverge about five years. So it may be a little bit too tight for the SMART trial to identify a difference, but one can expect if the patient is going to live more than 5, 6, 7 years and has a severe patient prosthesis mismatch, is likely to die a little bit more than a patient without a mismatch. So this is the kind of new platform that you're going to have in your cath lab. And it was, I have to say that I was quite surprised to see these large EOAs and low gradients with a balloon expandable valve. It was quite a surprise, competing with the self-expanding supraannular platform. It may have something to do with the design, with these intermediate sizes, the way the leaflets are sutured, but definitely for our patients, this is an added value, another element to make sure that we have something that is durable. You've seen these slides. We have to be prepared. It's going to be maybe not a tsunami, but a big wave of redo procedures. So we have to be prepared to treat these patients. So we're going to have a forward integration and discussion about the risk of redo procedures, how to prepare, but to make it short, risk of coronary obstruction and sinus sequestration, difficulty to get access to the coronary arteries, leaflet overhang, we can discuss that, and most importantly, as you've seen through the cases, with the under-expansion, the hemodynamic is impacted. It may be furthermore impacted after a redo procedure. So I'll go quite fast on that because we have something that is prepared, a talk on that. This is the shortcut device. We've talked about the leaflet modification. You've seen the Basilica case. In the future, we're going to have dedicated leaflet splitting devices. Shortcut is going to be CE mark ideally this year. And if the timing is appropriate, maybe at London Valve, we're going to do a live case with that just to showcase what the technology can do. And definitely, this is going to help us treat our patients because we're going to be able to slice 1 or 2 leaflets at the same time during the same procedure, faster and shorter procedures, and safer at the end of the day. So this is the Redo TAVI app that you may use. I'm not a big fan of all these things, so it's a community, we are here to exchange, so a bit of controversy is sometimes welcome. This is theory. This is pure theory with devices that are well expanded. There is no leaflet. It's never taken into consideration the thickness of the leaflets. And all these apps assume the fact that we are going to be extremely perfect at landing the devices. And you see through the cases that it's not always always the case. So I'm not a super big fan of all these apps, but they are here. Potentially in the future, more emphasis on this simulation, virtual simulation of the devices. I think this makes more sense than only a app with a fully expanded device. It's really going to integrate the shape of the failing device of our patient and help us select the appropriate one. So the choice of the first THV matters. And to conclude and leave the space for a discussion, so clearly TAVI has quickly expanded to lower risk patients. Through the discussion that we had yesterday during dinner, understood that you are still treating slightly older patients, but definitely there is no reason why you would not be able to allowed to treat younger patients, because that's a reality in Europe, and with the durability of the devices, we can aim at 1 or 2 procedures for a patient. So life expectancy of the patient is a core and central element of decision making. The durability is favorably compares with the surgical platforms that we have, up to 10 years, even with the early iteration of the self-expanding valve. So this is super reassuring. Hemodynamics, to my opinion, play a role, even if the literature is going to be a little bit limited to demonstrate that. Unless we have like 10 years follow-up of our patients, it's going to be difficult to demonstrate, but it has an impact in surgery. It's likely that it's going to impact TAVI as well. And we said the choice of the first valve matters, the index procedure, and it should integrate that index procedure, anything that is required to make sure that the redo procedure is going to be feasible. Thank you very much. Obrigado.
Thank you very much for your excellent talk, Didier. We will move to the next talk for the sake of time, do the discussion in the end. And the next guest is Dr. Arif Kokar, that is a consultant cardiologist from UK, and correct me if I'm wrong, he's currently working at the Rick Hospital in Copenhagen on structural heart disease.
So it's a tough act to follow from Didier, so let me try. Hola, obrigada por me convidar. So, unfortunately, that's all I have. But no, thank you again for inviting me. It's always nice to come back to Portugal and be amongst many friends. And maybe one day I will eventually learn Portuguese. The topic is to talk about leaflet management, initially in the concept of valve-in-valve procedures, so TAV in SAV, but also TAV in TAV. Really, I'm not going to talk about leaflet modification for TAVI and surgical valves. I simply point out this publication. I think it has everything that you need to know if you are starting to think about this procedure, what you need to study, the planning, the CT scan, materials, things to watch out for. It really, really is a very nice step-by-step procedure. And I think basilica in the setting, or let's say leaflet modification for surgical valves, it's been well studied, it works well, there are now dedicated devices which are coming, so I think this is a relatively mature field. Instead, what I want to focus on a little bit is redo TAVI, because leaflet modification in the setting of redo TAVI is extremely complex. It's not so mature, the field, and we are learning and a lot more about this every day because procedural volume is less. Part of the problem is no redo TAVI procedure is sometimes the same. You have all these different valve combinations, which you can broadly split into these categories: short and short, short and tall, tall and short, and tall and tall. And then the neoskirt plane, which dictates your coronary obstruction risk, can vary depending on how you implant your valve. So you can end up with unlimited number of configurations, which can increase or decrease your risk of coronary obstruction. Then what's really difficult is now we have so many different leaflet modification techniques or devices. Almost every week you see in a new journal article there's a new type of corn. Unicorn, llama corn, baby corn I found the other week. So new ones keep coming up. To keep it simple, you can split it, I think, into electrosurgical techniques or mechanical techniques. Are you achieving a leaflet splay, or are you mechanically sort of disrupting the leaflet? Do you use a dedicated device or off-shelf techniques, and do you have to combine? So these are kind of the categories, and I'm going to focus on my talk a little bit on the principles with leaflet modification rather than any one specific device. So why do we think about leaflet modification for TAV and TAV? This is a real-world analysis that we did in Copenhagen, where we looked at real post-implantation CT scans across 4 different valve combinations. If you have commissural alignment, then you can see leaflet modification can really increase the feasibility for a redo TAVI procedure. So we talk about lifetime management, and really leaflet modification is a part of a lifetime management strategy that allows you to do a redo TAVI procedure, but you need to ensure your index valve design, the implantation depth, and commissural alignment. So we talk about very complex and fancy things, but really that first valve that we implant, if we just align it and pay attention to optimizing that procedure, you can set up a good lifetime journey. So let's get into it. What are we talking about with leaflet modification? This is an example in bench of a Sapien and Accurate. You can see the leaflet neoskirt, which is the pinned up leaflets of the Accurate, and the catheter is trapped. That's the leaflet neoskirt causing obstruction. We do basilica, and this is what it achieves. So you can see how leaflet modification can help, and you create that basically cut inside of the leaflet neoskirt, and you allow perfusion and coronary access. I'm going to focus on these three techniques: basilica, balloon-assisted basilica, which is after traversal. You inflate a 4 or a 5 millimeter coronary balloon, and what that is aiming to do is to increase the width of the splay right down at the bottom of the V. That's the rationale for the balloon-assisted basilica. And then on the right, we have the unicorn, which is you traverse the leaflet, you inflate some balloons, and then you deploy your second valve inside the leaflet. And I'll just talk you through these. So I've just taken sapien and evolutes as the most commonest valves that we treat. Here you can see basilica, balloon basilica, and unicorn. What we've done is we've done these three different techniques, inflated a balloon on the inside, just to give you a visual idea of how it looks. You can see both basilica, balloon basilica, you create this vertical V-shaped splay, number one. Maybe with balloon basilica, you have a slight increase in the splay, particularly when it's a sapien. And of course, you can see with unicorn, you get the largest splay area because you effectively remove the leaflet out the way. Now, one thing to highlight is that these tall frame valves, which have a cage, you can sometimes pin your leaflet after you do your leaflet modification back against the cage. So what that means is that you might not get as big a splay as, for example, you've seen the images in surgical valves where they show the basilica is done and then the valve, the leaflets fall open. They will not fall open if you have an evolute or an avator because you'll be trapped against that cage. So that's one thing to highlight here. Second, in a redo TAVI setting, there is something that we need to think of. So this is a sapien in a sapien. In the gray, we've done the unicorn procedure and we've highlighted the leaflet splay area that you achieve. Now, when you put a second valve inside of the first valve, you can get some obstruction of the splay area because of either the inner or outer skirt of either the first or the second valve. And this splay obstruction can then cause some problems of the actual splay you've achieved. So what's relevant is the functional splay area after you do your leaflet modification. So I just want to highlight this concept because I will show you some cases now and some examples where you do your leaflet modification, you think you've created a gap, but then it gets blocked. And that's because there are elements of your second valve which can block the splay that you achieve. So let's look at some examples. This is short in short. Again, we've done basilica, balloon basilica, and unicorn. You can see that the basilicas, let's say, create a very similar splay. I think maybe with balloon basilica, a slightly increased splay. Unicorn certainly gives you the largest functional splay area in this setting. When we look at the combination of short and tall, again, here with the basilicas, you see that these leaflets can be pinned open. This is shown in a worst case scenario. So the leaflets can be pinned open, so is not so large, that splay. There is this idea that we'll do basilica and we'll dramatically open this place, but actually these leaflets can create a very narrow slit. So that's something to be aware of. And then if you look at unicorn, you can have the largest splay area in this setting. Now it's different when you think of tall and short. That's written incorrectly. This should be tall and short combination. So basilica, balloon basilica, fine. You make the splay, you get a nice splay. And here you can see unicorn, caution advised. And I'll talk to you a little bit later on about why that is, but this is an important thing. For me, and I'm interested to hear people's experiences as well with this scenario, I think the tall and short combination is probably the most challenging for leaflet modification. And I'm going to show you some examples of why that might be. Then, it's not just leaflet modification and what technique you use, it's also how you implant your second valve. Look at these examples. These are tall and short. And if you align your evolute, you keep that splay open and you get the benefit of doing that splay. Contrast that with if you end up with your evolute completely misaligned, or for example, if it's an avator, you block the splay that you achieve of the sapien. So you go through all that effort, you invest in the procedure, you do your basilica, and then you've blocked your splay. So you haven't actually achieved anything. So alignment also of your second valve matters. And in this combination, also the implantation depth matters. So let's say you do your basilica of the sapien, you come with your evolute. If you see in the middle panel, this is inflow to inflow. Okay, you have a little bit of blockage, but you have your splay open. If you end up with your evolute slightly higher, the pericardial skirt of the evolute, which comes to node 3, which is the base of the leaflets, will block your splay. So again, you mentioned and showed very nicely that these valves behave unpredictably. We cannot be as precise as maybe in a native anatomy. And so if you just end up with that evolute a little bit higher, you will completely block your splay. So this is why I say that the tall and short combination is a really challenging scenario. So let's get into some cases. This is an 85-year-old. This was a degenerated evolute 34, mixed disease, but predominantly aortic insufficiency, presented with an acute valve syndrome. This is actually a case performed by a colleague, and sharing this image with his permission. So if we just briefly look at the CT analysis, the VT-STJ is 0. So this was deemed to be very high risk. Also, the level of the coronaries were sort of within 3 millimeters. So the conclusion from the CT analysis, as this is high risk for coronary obstruction of both coronary arteries. So something needs to be done. So the plan in this particular case was to do bilateral balloon-assisted basilica sequentially, the left and the right. The left, I think, took about 10-15 minutes to do. The right took a couple of hours because of finding the shape, the catheters, and trying to do it. So what I emphasize is that it took a long time, really long time, very complex procedure to achieve the balloon-assisted basilica, but it went well, uncomplicated. And now look, I'm just going to play the video and just watch what happens to the sapien. It comes to exactly what you said, Didier, that as soon as metal hits metal, you don't have as much control. The target was node 5, and you can see here, even when trying to push that valve, it ends up probably around node 7 almost. So, I think we always talk, again, you mentioned this precision of we will land it at 4, it will be okay, but at 5, we are not sure. I think you have to build in a safety margin because these valves do not behave as you intend to. What happened? Look at this angio. Complete obstruction. So despite a very successful balloon-assisted basilica, you then had complete obstruction. And if you see on this next image here, you can see on the semi-selective injection, you had complete obstruction of the left coronary artery. So I want to understand and show you why. This is in vivo images. On the left panel, what you can see is that one of the posts of the sapien ended up directly in front of the left main, and also the pericardial covering. I said that, we have these parts of the second valve which can block your splay. That's what's happened here with the sapien. So just to highlight that really clearly, this is the explanation for what happened in this case. On the left, if the basilica was done and the sapien was implanted at node 5, your splay would be open. What ended up happening here, the sapien ended up at node 7, so you got some obstruction of your splay. So you did not get the maximal benefit of that balloon-assisted basilica, number 1. Number 2, you also ended up with misalignment of your sapien, which we cannot predict. It's impossible to align a sapien. So the combination of the two meant that no matter how successful was your leaflet modification strategy, you lost the effect. And this is why this is a completely different game, almost, leaflet modification in redo TAVI. And there's so many things to be aware of. And here you can see these are some, again, bench examples just to highlight the importance of alignment. This is a sapien in an accurate. We've done the basilica of the accurate, which is misaligned, and you get no benefit. So if your first valve is misaligned, you can do whatever you want. You may not get a benefit. So that's why index valve optimization matters. Other way around, you do your basilica to your accurate, you implant your sapien, maybe it's not playing, but basically you end up with the post of the sapien and it blocks you, so you don't get much of a benefit. So that's a really important point about the alignment. Now I show you another case. This is a case that we had last year in Copenhagen. 77-year-old patient, large accurate neo, presented with severe aortic insufficiency. Just to quickly go through the CT scan, this is a nice example. So strictly, if we target to implant a short frame valve at the upper crown, we are probably borderline or okay. If the valve goes a little bit higher, 2 millimeters higher, it would be high risk for obstruction. So rather than thinking that we can be super precise, we thought we would build in some safety margin and do some form of leaflet modification. Our plan here was to do the unicorn procedure. So here you've got a 8 French AL3 guide in the left cusp. You then come through with a 5 French multipurpose as a mother and child, bring in an Estato and traverse the leaflet. That was fairly straightforward. Then starts a period of sequential balloon dilatation. So we went first with a 3 coronary balloon, 5 coronary balloon, 12 armada. This was actually our first unicorn in a TAV and TAV setting, so there is also a lot of learning in this case. If you look carefully at that 12, you saw a waist at the beginning, which then disappeared. So probably we had created enough of a hole, but nevertheless, we wanted to be sure the sapien would cross. So we went ahead with an 18 true balloon, and you can see how the balloon suddenly shifts, telling you that that leaflet has avulsed and completely broken. Unsurprisingly, what happened? The patient just dropped the blood pressure down to 40 systolic, and then you're rushing. Then you're rushing and trying to be really fast and deploy the valve. Nevertheless, it went fine. You can see how the sapien behaves. It's moving up and down a lot more because we've got regurgitation, but also these are difficult, but we achieved the target depth. We have no obstruction. So here, this was a successful case. It's very interesting when you look at the post-CT. So here you see we achieved the target depth that we wanted to. We got the sapien just below the level of the left main, so that all looks very good. And you can see just here, retrospectively, was there a need for leaflet modification? I think probably, because you see the gap here, the VT SDJ, this is not VT, it's not virtual, it's actually measured, was 1.4. And that blue line is exactly where we did the unicorn and moved the leaflet out the way. So I think in hindsight, yes, probably it was helpful. But what's really interesting is when you look at the CT scan and you look at throughout the cardiac cycle, in yellow dash is the other leaflet, which is leaflet overhang, because we've got the sapien in a low position. In red is the unicorn leaflet. And what you see, it's basically flapping around. So because this leaflet was completely avulsed, it didn't get trapped. And I think probably we just got lucky in this scenario. And I'm going to show you what I mean by that. So there is these 2 different scenarios that you can face with, let's say, unicorn or intraleaflet deployment. This scenario is whereby you're coming with your sapien and you have already broken your valve leaflet. And so what happens is that valve can just move anywhere, and you have a completely unpredictable scenario. You don't know where that leaflet is going to end up. Versus, you come with your sapien inside the leaflet, and you use your sapien inflation to break open the leaflet. And these are 2 conceptually very different things, but very, very important to understand. So unicorn is whereby you come with the balloon inside the valve, you create a hole or a fenestration in the leaflet, and you use a balloon expandable valve to break that leaflet open at the same time. That's the classical unicorn technique. And that is different to what some people are calling lamacorn, which is whereby you break the leaflet already. And we've done these bench tests with different valves, and of course it is only bench testing, but the leaflet never breaks and flies off. It always stays attached at one commissure and just detaches along the suture line. But then you can see it can move anywhere. And then you have to come with your second valve, and then you end up with a completely unreliable result. So just to highlight that and make it very clear, you can see the difference between these 2. On the left, you have the classic unicorn, where the valve will come through the hole, and on the right, the lamacorn, where the leaflet is completely flying and you have a very unpredictable result. But the question is, can you do unicorn if your second valve is a self-expanding valve? And this is why I think tall and short is very difficult in this scenario. So these are just some examples where we had the unicorn and we tried to deploy self-expanding valves, and you can see it doesn't open. That self-expanding valve will just not open. It doesn't have sufficient opening force to break that leaflet. And then you basically end up in this extremely constrained self-expanding valve, and then you have to do a post-dilatation, and that post-dilatation will break the leaflet. So this is really a scenario that you want to try to avoid. So to overcome this problem, what some people suggest is that if you are using a tall frame valve as your second, then you can do the Lamarcorn concept, whereby you come through, break the leaflet, come with your second valve, and then you can deploy it. Now, again, in theory, okay, it makes sense because now you don't have this issue of the valve being stuck within the leaflet, but it's completely unpredictable. You have no idea what is going to happen to that broken leaflet. You may, like on the left-hand side, get a perfect result and get very lucky. The leaflet gets trapped away from the target sinus. Or, in the worst case scenario, and this has happened in some cases, just this morning we were discussing a case that someone experienced, the same thing happened. Your leaflet gets completely trapped, and so you do not get any benefit. And this is why I say tall and short is very challenging with leaflet modification. Your alignment matters, your implantation depth matters, unicorn is difficult, may not work, Lamarcorn is unpredictable. So eventually, hopefully with dedicated devices, something will come forward. So final take-home messages to try to summarize all of this. Really, I think leaflet modification in the setting of redo TAVI is complicated because of the different combinations we have and all the different things we have to think about in terms of the alignment, the depth, etc. Unicorn in general, when it's feasible, creates a much larger splay than a basilica or balloon basilica. We have to be aware that we can block our splay, as you saw in that first case, because of a period of covering from the valve. What you then do with your second valve can also compromise your leaflet modification, so we have to be careful there. And for me, there is still a lot to do, a lot to discover and develop techniques for when you use a self-expanding valve as a second valve, and Unicorn, Lamarcorn are maybe imperfect solutions. So, thank you.
Thank you very much, Arif. Maybe we'll do the discussion at the end. So we'll move on to Ruben Ramos, interventional cardiologist in Santa Marta. We'll talk about how to optimize the index TAVI for future redo TAVI.
Obrigado, Joana. Great responsibility. Talking right after Didier and Arif, such experienced operators. I'll do my best. But probably they did most of my case because they showed what the challenges are in doing TAVI in TAVI. So maybe the best thing is to avoid it altogether if possible. So what I'm going to talk in the next 10 to 15 minutes is how to optimize our first TAVI so we don't have to do, if possible, the second one. So you've seen this slide before. The difference now, maybe even in Portugal, is not treating older patients that we're not expecting to live 10 years or more, just anymore. We're not treating younger patients with very high risk, which also will not live longer. But now we're diving into the group of patients that's young and low risk. So probably they'll have 10 to 15 years to live. So how can we get the best of the first TAVI is the point. So we're not looking anymore, just trying to get the patient safely out of the cath lab, but we also we don't want them to come back. So how can we do that? So the first step, I think, is the most important one, is to select the patient right. So not just because we can do it at 70 years old or 75, that probably should do it. That's, I think, the most important step for the optimal TAVI procedure. So this is I'll show a couple of cases. So most of I'm going to talk here is after Didier and Arif. I'm not talking about guidelines and experience. We'll just talk about my own and experience or my center experience. So this is a 76 bicuspid low-risk patient. We could do it. Monday we did a case just similar to this in an 80-something patient. It was okay, but for this patient, 76 bicuspid, very calcified raphe, we didn't do it. We sent it to surgeons. This one, again, young, low-risk patient, eccentric LVOT calcification. We've done so many cases like this. It's unpredictable. Sometimes we got a fine result, no leak or trace. Sometimes you get a massive leak or regurgitation or an expanded valve. At a 74 with low risk, we didn't do it either. A very common scenario, young female, low risk, small area, low RCA. I mean, we can do these cases. We all have done these cases. It probably has a good chance of the first TAVI to get a good result. But is this the right thing to do at this age and risk level? Probably not. So, can you? The video is not running. Can you? Yeah. Okay. Okay. So probably we should have sent this patient to surgery, because sometimes we get with this kind of results that you cannot treat altogether. After the first TAVI is in, then you're done. So I think the first step and the most important one is to select the patients right, so we get the best chance of treating. So can you go back, please? The slides are moving. Okay. So once we decide the patient is going for TAVI, if it's the right patient, if it's the right thing to do, then the second step is what's the valve, what's the best match for this patient. So basically what kills the redo TAVI, what will make it impossible or very difficult to do. We've seen what can happen in redo TAVI. So basically, if you have small aortic root anatomy, we have the risk of sinus sequestration, or if we have commissure misalignment or putting tall in tall, we have very high risk of not have coronary accessibility, or if we have a small annulus, the risk of PPM very soon is high. So small anatomy and coronary misalignment is mostly the challenging, where the challenge is coming from. So this is, again, another case. So I think we should avoid this if we can, and avoid this trap. And this is, okay, you'll do this once, your risk for the first TAVI is low, you do this, you're 70-something, you do, and then you're done. Sometimes it's not that. This is a 70-year-old female, symptomatic, very active woman. She's an entrepreneur, has 10 or 15 employees. She wants to go back to her normal life. She doesn't want surgery, so she agrees to aortic valve replacement only if it's TAVI. But here's the thing: she's a small annulus, around 390. The sinus is not very large. The LCA is 7.8, the height, left coronary height. So low coronaries and relatively small anatomy. We decided to offer TAVI and in the heart team, so she agreed, and the TAVI was implanted and optimized post-dilatation. But was this the right thing to do? So let's say 8 to 10 years from now, she comes again, and with a degenerated sapien. Now her VTA is 2 to 3 millimeters. It's very small anatomy. What we do? Now we move to balloon to leaflet modification. We have seen what can go wrong here. Is this good enough for this 70-year-old patient? Are we really relying on basilic or unicorn or lamacorn or whatever for this kind of patients, low-risk young patients? Maybe with another leaflet technology, modification technology, maybe. But at this point, I don't think we're ready for these patients with borderline anatomy, even though if the first TAVI could be fine, but I think we should think forehead and say how the TAVI will look like. If the TAVI looks dangerous, maybe we should adapt our strategy. Different valve, even different options. Maybe surgery is a better option for these patients, for some of these patients, even if TAVI, for the first TAVI, it could be a good result. I don't know the answer. So this is my, this is my personal algorithm. This is how it's not even written. It's how I think when I'm trying to decide what to do with the patient. So if the patient is low risk and has a small annulus, my first question is the anatomy favorable for the future TAVI? So high coronary arteries, relatively large aortic group anatomy, no major bulky leaflet calcification, and if the annulus is big enough to take a second TAVI in the future if necessary. If the answer is yes, then okay, we move on. If the annulus is very small, in the lower end, I tend to go with the supraannulus self-expandable valve. If it's small but not very small, we can even use an intraannular self-expandable valve. If the coronary is critical because previous coronary disease or some concern, we might need very high likelihood of coronary access, then we go with a short stent frame. If the anatomy is not favorable, it doesn't look favorable for future TAVI, so small annulus, my second question is aortic root feasible? And also, will my surgeon do it? Because sometimes we have these patients and send them to surgery, they got in a small valve, either way. So that's not the right solution. So my question is, will do aortic root enlargement or some technique to improve the area or the anatomy? If the answer is yes, maybe surgery is the best thing for these patients. If the answer is no, then we have to move on. And maybe, in my mind, this can be a good option because we can aim for commissure alignment with this octa-align technique. We can get bigger effective orifice area. So this kind of technology and devices may be a good compromise, a good solution for these patients. Now we've decided the patient should go to TAVI. We've chosen the valve. Now it's the technique. So we all know that under expansion comes with a price, not only stenotic or hemodynamic gradient, but also regurgitation. And we have ways to look at it. Maybe sometimes we don't put too much effort into it, so we can try to see there's all this several hints, a post, parallel post, or asymmetric expansion, and some constrained stent frame. So we can look into it to see whether we've done a good job and try to optimize it. And we know, or at least we think that end expansion comes with a price, not only the degenerative, but maybe even mortality or hard endpoints, clinical endpoints. So it can be a major issue. So again, this is a case very, very similar to what I've shown you before that we rejected, we sent to surgery, but in this case, we did it as a 80-something patient. And as you can see, we put in a 29 evolute, even after pre-dilatation. You can see after post-dilatation, you can see the results. So here you can see in the short axis, the stent is very constrained, so it's very eccentric. This is not something we do all the time, but now I'm trying to do it almost in every case, especially if bicuspid place, to get this short axis view. Sometimes we cannot do it because it's too steep, the angle. But when we can, it's nice to see whether the result is good, as acceptable or not. And often we see that the valve is not as expanded as you might think in the normal views. And also it allows you to see the commissure alignment. You can see the left coronary, the right coronary, and you see the post here perfectly. So you know that you have not only commissure alignment, but also have coronary alignment in these cases. So there is some ways to assess this, not only CT scan. You can get this from the cath lab and see if you've done a good job in the first TAVI. Also, there's another scenario which is patients with large anatomies. When you think you might need a good post-dilatation, I think here we can, such as in this case, we have a 26 area. We could go 26 annulus. We can go with an Evolut, or if we choose a self-expandable, or an Navitor or another platform. But you see, if you go to an Evolut, we're somewhat limited by the valve, the device itself, because it's constrained in the waist. The waist limits us to 23 or maybe 24 balloon for post-dilatation, whether in other platforms we can go almost nominal to the valve area. So in this case, we've chosen a Navitor. You can see here after deployment, the valve is constrained, but then we went with a 26 balloon. If we were here with the Evolut, maybe we couldn't do it. We had to go with a 24, 23, 24. But in this case, we were able to get a 26 and improve the result. So I think there is room for improvement when we choose our devices. And finally, just to finish, in the commissure alignment, it's not only for coronary access. It can be nice to have a large cell devices to get through and have coronary access, but also it seems that commissure alignment is also important for regurgitation and valve durability. So it's something we should put some effort into to try to get the best of the first valve. So far, it's not possible with all the devices, all the technology available. Evolut now make it a little bit easier with this technique, or with post-rotating in the descending aorta according to anatomy to try to get it. It's been reported to get commissure alignment up to 96%. In our experience, it doesn't work that frequently, but most times you get it right. And I think at least once we can try and do the commissure alignment in the first valve. So final take-home message. I think the first thing and most important is the right patient. Then we choose the patient, we decide to move on, then choosing the best valve, the best match for the best patient, and try to optimize the depth, expansion, and coronary alignment, so we can get these valves to last as long as possible and try to avoid the redo TAVI. Thank you.
Thank you for your excellent talk. We will move for the discussion. So I kindly request each member of the panel a short question, please.
Just a short question, and we take the advantage of having here Didier with us. When we have these patients that we are following up and the gradient increases, in your experience, do you first try to start the patient on NOAC, waiting if the gradient goes out, assuming that it can be like subclinical leaflet thrombosis, or what is your usual strategy? And the other comment is that the cases that you've shown us, and also in the other presentations, when these valves degenerate, they almost don't have any calcium. That also probably is one of the technical challenges, like you showed us, of being able to implant the valve on the right position. And your second case was really tough because you have all this valve without calcium and also a very horizontal aorta, so quite challenging to implant and evolute.
Yeah, definitely. To make it short, in fact, as soon as you see a high gradient, one must think about leaflet thrombosis, whether it be heart or harm. So we need to apply the proper assessment tools, the CT scan, TOE, just to make sure that we identify that issue. And it's true that when you put the patients under anticoagulation, it resolves. We have a window like 3 to 6 months. If we identify that, within 3 to 6 months, we can go back to the initial status. If we wait too long, then the degeneration process starts, and it's a kind of too late. And yeah, it's true, sometimes we don't have that much calcium. So I do believe that thrombus formation has an impact on the durability, and if we identify that quite early, that could be beneficial.
I would just like to thank all the presentations because they were very good, and this is a new topic. There are not so many cases done as you showed us. I would just like to comment on another care that we must take. We've been talking about coronary obstruction. We've been talking about hemodynamics post-second TAVI with the overhang. But I think we must also pay attention to the native anatomy. I think about cases in which I want to place a balloon expandable valve in an anatomy when the first index TAVI was chosen because of massive calcification of the annulus of the LVOT. And in this case, it's not only the coronaries, it's not only the overhang, but even if we choose a slightly undersized valve, there is problem on the aortic root, particularly if there is much calcification and a tubular aortic root. So I'd just like to make this comment because I have a case in which there was a slight aortic dissection, fortunately not evolved wrongly, but there is some problems also with the native anatomy.
I just want to do a comment. We still don't have much experience in these cases, but I think that we know that we have to put the first TAVI looking for the redo TAVI. So we are learning with this experience, this not so good first cases, and I'm sure that now we are going to do, we are going to get better results, and we are going to choose wisely our candidates. So I'm sure that in the future, maybe the redo TAVI won't be so challenging. I hope.
Thank you. I have no experience involving valve or TAVI in TAVI, but I have to decide and to choose the first device often. But normally it's for people above 80 years old, and I'm not worried about the second TAVI, but I agree with Ruben that if we are treating younger patients, we need to think about that. So what I would like to see is a risk score that predicts the risk of coronary obstruction in the second TAVI procedure, or maybe AI could help us in the future, because I think that it could help us to choose between valves and also the depth of the implantation. Do you want to comment, please? Yes, Arif.
Yeah, so of course, artificial intelligence will tell us the answer. I'll tell you something from human intelligence. It's nice that you had this algorithm. If I see a young patient, the first parameter I look at on the index CT is the sinotubular junction height. And if I see that it's 20 millimeters or less, I start to think already, okay, let me look in more detail at this anatomy. If I put a first valve, if I put this valve, can I have a redo TAVI procedure? Probably the number is not 20. I have a feeling the number is 18 millimeters, but it's easy to remember 20. So I would say to everybody, if you see STJ height on the left or the right, because it can be different, below 20 millimeters, start in your head thinking about what to do with your first valve. Actually, you can even go one step further and look at the aortic annulus area, the sinotubular junction height, and the sinotubular junction diameter. These three numbers will dictate what size sapien you put in as valve 1 or 2 for a redo TAVI, and just with these three numbers you can work out if you might have a problem, and then you can anticipate and do something with your index procedure. So for me, with a very simple human intelligence, I just look at STJ heights. Once I see 20, I'm already starting to look in more detail.
And do you modify your depth of implantation?
This is always asked. So I think in general, you don't want to compromise your first procedure because you don't know what will happen to that patient. So you want the most optimal first valve implantation, avoid a pacemaker, which is, you don't want to have a pacemaker in these young patients. Avoid PVL, superskirt leak, all these things. So I think you try to optimize your first. But what I would do, for example, let's say I have STJ of 18. I would then make sure, and let's say it's a small annulus, I would make sure I take a supraannular valve that I can do commissural alignment. Because then you can do something to the leaflets if it's aligned. So in this way, try to anticipate what might help me at the second.
Congratulations for all your talks were very enlightening. I just want to have a quick answer from Arif. When you're talking about leaflet modification, so it seems to me that probably balloon-assisted basilica would be one of the best choices of overall addressing this issue. And also a quick question to Ruben. So I followed your presentation very wisely. So when you have a young patient that is feasible for TAVI, so this is pretty much also, and you don't have so good anatomy, so you have to explain sometimes very detailed all of these pros and cons, but sometimes the patient still wants to go forward with a TAVI. So you have to, overall, if you have a patient that you wanted to advise for surgery, what is your next step? Do you try to change it, or will you just try to accommodate this shared decision with him? And I'm thinking also, sometimes we have a lot of referring patients that they just end up doing the procedure at that day at our center, especially when you have a referral center. What about all of these patients? Sometimes you don't have so much clinical follow-up, you're not your assistant cardiologist. So how do you cope with all of this with these patients?
I'll quickly take the balloon-assisted basilica. Look, we have to be humble and honest. What I showed you on bench is a mix of best-case scenario, worst-case scenario. It was more to illustrate some principles. Is it the best? Honestly, I don't know, because I don't have that much experience in the redo TAVI setting as to which technique for which scenario, for which combination is the best. Didier, maybe you have much more experience with leaflet modification. What's your opinion on balloon basilica in this setting?
Yeah, just a quick answer. In the vast majority of my cases now, I've switched to Unicorn. Unicorn is faster, easier, more reliable, as long as you remain intra-leaflet, as it has been demonstrated by Arif. If you go for a Yamacorn, what I do now, I protect the coronary arteries with a guiding catheter, deploy the valve, and then you are ready, because from time to time you get a movement of the splayed leaflet in front of the coronary ostium.
Okay. It was oh, sorry,
It's okay. It's okay. Yeah, the one patient, how to deal with. I don't know. The honest answer is that I just try to explain the patient what's the scenario. Most times it's not me that's seeing the patient in the visit, so I'm not seeing these patients in the visit. I'm just getting the CT and the patient's referred for TAVI. Then I go through the procedures and talk to the referring doctor. Most times I don't even see the patient before. So I talk to the referring cardiologist and explain what's in my mind, and then they convey this to the patient. Sometimes patients agree, sometimes they don't, like I showed in this case, if the patient don't agree, so we move forward with the best solution we have. But at least I make sure that everybody understands what the implications are, especially, like I said, in young patients with small area. For me, it's the tiebreaker. But even if you can do it in the small area, the risk of PPM is so high that sometimes that then you're done. Then you don't have a way back. So the best way to deal with this, to navigate all this, these parameters, I don't know what's the right answer.
So, it was an excellent talk, very complex one, with excellent presentations, a little bit elusive regarding the conclusion. So I would like to end up with a simple question for both of you. Imagine you have a 70 years old and you have a perfectly healthy aortic stenosis. How do you want it to be treated? Assume the average sizes.
70 years old.
Healthy guy.
TAVI 100%, unless I have some hostile anatomy, extremely calcified bicuspid, risk of coronary obstruction, blah, blah, blah. I would go for TAVI for sure, definitely. Then the debate, self-expanding, balloon expandable. I want the best operator using the best platform that he masters to treat me. If you're not everybody, we have different mindsets, and some are super experts for self-expanding, some are super experts for sizing and deployment of balloon expandable valves, and I want that type of operator. But definitely I would choose a TAVI procedure.
In addition to those things, I would look at the aortic root geometry. So if huge aortic root and redo TAVI seems like it would be without any problems or need anything. To be honest, I would choose surgery if it's me. I mean, this is just my honest opinion. But the data, but to be honest, the data, if we look at, is for tricuspid native aortic stenosis. If you look at Notion 2, for example, median age 70, STS 1.1, equivalent. So if we fully follow the data based on maybe 5 randomized trials with high expertise and skill, I think you can get equivalence. But for me, I would look at in addition to the hostile features, the root geometry to decide. And I think I want to just follow on your comment. It's so, when we think of these younger patients and we think about surgery versus TAVI, I think having that CT scan at the beginning, before the heart team, can be really, really informative. Not only for, let's say, bicuspid or the calcification pattern, but also root geometry. So doing this, it's maybe not easy in every healthcare setup to have CTs on all patients, but maybe every patient between 70 and 75, let's say, should have a CT scan before going to the heart team. Then you can decide on hostile anatomy, aortic root geometry, and think what might be the best scenario.
It's still elusive. What I wanted to know is surgery.
I said surgery, yeah.
Okay. So it's a kind of balloon expandable.
Yeah. I should add also it's what kind of surgery, because sometimes we send patients to surgery that get a biological valve, small valve, that we can do with TAVI. It's not just surgery, it's what kind of surgery you're offering to the patient. Because if they're not doing aortic root enlargement of some kind of optimization, then we can put a biologic valve, small valve, either sometimes even with a higher effective orifice area than the surgical ones. So it's not just surgery, it's what kind of surgery you're offering to these patients.
Okay, thank you.
Yeah. Okay. So, yeah, please. Hello, everybody. Thank you for staying until this very last session. First of all, I would like to thank you, Claudia, and all the organization for inviting us as the Spanish representation for this amazing session, a joint session between EPIC and CSC, in which we will see 4 really challenging cases. So please, Rui.
Okay, so for me it's also a pleasure to moderate this session. We have very experienced fellows there. Arif Kokar, Claudia, Jorge, and Lino Patricio. Hello. Good afternoon. So I think this is going to be a very interesting session about complex cases. I'm going to pass you the word so that you can present the first speaker.
So we have our 4 blocks of 20 minutes. So we will ask the 2 first speakers is Duarte Casella and Julio Echarte. Please, Duarte, he will present our first case, and then Julio Echarte will say how he would treat.
So, good afternoon. I'm supposed to present a difficult, unquote, case. Is this moving? So, the title is Mission Impossible, whatever. So, I have this patient. He's a 79-year-old male with a mechanical centured 21 in 2008. I lost. The Spanish people are boycotting this. Can you go back, please, on the first slide? The other one? Okay, thank you. So in 2021, he had a cath, he had an occluded lima. In 2023, he had a CRTD, and last year he entered with progressive heart failure with 2 hospital admissions on the second semester of 2025. And the echoes showed the deterioration of the LV function with a 34% ejection fraction and an increase on the transvalvular hemodynamic parameters with a mean gradient of the aortic prosthesis of 25 and a velocity of 3.3. And a suspicion of a motionless disc was raised. Then in October, he was recath. We found restenosis of the LAD stent and a de novo lesion of the OM1 branch. He had a deb on the LAD and a stent on the OM1. Is the video playing? Can you put the video playing, please? The video? It's supposed to, okay, all right. Okay, so look at the disc. He has a more or less fixed disc. So as far as I don't have it, okay. As far as non-cardiac comorbidities, he has a polycythemia with 3 previous phlebotomies, he has diabetes, chronic renal disease, and he had 2 hematomas, brain hematomas, 2 of which, being quite voluminous, had to be drained in June and September. And in September, he underwent a medial meningeal artery embolization. And during these months, for more than one time, anticoagulation had to be reversed with intravenously administration of vitamin K antagonists. So, and at this time, both patient and family refused redo open heart surgery and specifically asked for a less invasive alternative. The Euroscore 2 was 19.4, and the case was discussed with his cardiologist, who agreed on a less invasive approach. Those are the accesses. So we have a very severe calcification on both axes, and both iliac and femoral arteries are in the 5 to 6 at the most range. So the video is not playing again, please. Can you put the video playing, please? So, Julie, what would you do? No, I don't think so.
Okay. So, Julie, you are coming from Vigo.
From Vigo, yes.
And you were in Montefiore with Azim.
Yep.
Right. Okay. So you should know how to solve this.
Yeah. Thank you. Still am interventional cardiology fellow. No, joking. Yeah, I am. I don't know if my slide will be here. Yeah, it is. So thank you for the invitation. Thank you for the kind introduction. Let's see. Yep. I don't know now. It's done. So in order to summarize, Jos Duarte presented a 79 years old male. He underwent surgery with mechanical 21 and youth valve in the RT position. Now he has moderate to severe reduced ejection fraction with a mean RT gradient 25 millimeters of mercury, and importantly a fixed disc. Additionally, this patient had a high bleeding risk. He didn't want to go for further surgery for many reasons, and importantly, this patient has also hostile femoral access. So this is the usually in Vigo what we do with this. So this, of course, cardiac surgery is not an option. He refused, and this would be the second surgery. He's 80 years old almost. The surgical risk is very high. GDMT is not an option. Doing nothing is not an option. Also, so we will go with this. I have never seen a case of this before. I just read it. That we can call it the VaP-APIC. But what we know about TAVR in mechanical valves? So this is very timely because just came up from my point of view, 3 great papers last month in JACC. So the first one from Webb, they did an amazing job in bench test. On the right part of the slide, you can see that either with a balloon expandable or self-expandable valves, the hemodynamics, they are pretty well. And very important, on the left part of the slide, you have the 3 different, the most common, let's say, surgical valve use. On the middle, we have the St. Jude's valve, and this is the results on the first line. How are the discs dislodged? Usually they are retrieving one piece, but this usually happens when you have larger valves, more than 31 millimeters. The patient that just Duarte presented is 21 millimeters. So this was published also in the supplementary of this paper. This is the way that they did it in the bench test. You can see now in just a few seconds how this is completely dislodged. Actually, they present a case, but this is the mitral position. This is a St. Jude. I think that 23, you just saw it, how these were completely dislodged, and they finally, with the long pacing, they deployed a Sapien 3 in the ring of the St. Jude valve. It's very important to be aware that what they wanted to pay attention in this case is that either the inflow or the outflow, they wanted to be in this position with the flaring sides for possible better hemodynamic. This is the second paper that I mentioned that came up last month also. You have all the things, you have all the things that they wanted to yep.
Could you come back?
Yep.
It's interesting because the concept is nice, and I know that you guys did it the perfect way. But here, if you watch the ventricle...
Which video? The first one or the second one?
The second one. There is one of the leaflets that is
okay.
cruising in the ventricle.
This one. Yeah, I cannot pause here.
Yeah, this one.
Yeah. Yeah, what Didier just said, I don't know, I will put it again. You can see at the end of the valvuloplasty, the next one, that both these are completely removed. There. So this is the other paper. They went through all the things, the key findings of the paper, fluoroscopic, crossabilities, if it was easy or not, performance of different balloons that we have in the cath lab. Usually the best are the Atlas balloon and the True balloon also. Actually, we don't need to put like too much pressure, only from around 5 atmospheres for both of them. It would be enough in order to dislodge. On the right part of the slide is a very technical point of view. So in the letter A, you can put a wire. This is easier in patients with a larger valve, more than 31, because the distance between two leaflets usually with larger valve is more or equal than 4 millimeters. But in the case that just Duarte presented, that is only 21, probably it would be easier to put a wire in V or C position between the disc and the rim. But even in this way, you can remove also and dislodge both discs actually. If you have not like not a super lucky guy that day in the cath lab, and only you can remove only one disc, still you can deploy another valve and trap the other disc. Regarding the what happened when we moved from preclinical studies to first in human study, this just always came up, but in European Health Journal last month, this preclinical study was done in CENIC in Madrid. And the first 3 human cases, they did it with Evolute, and 2 of them with MyVal. In all of them, they used 2 axes, 2 wires, and 2 cerebral protection devices. And they use a different type of balloons. They use 12 and 18 millimeters balloons. So with all this information, what would I do? So what I do is, with this case, I would go 2 axes, one of them probably femoral artery, using the flower embolic protection device. The flower device needs a 12 French, that is around 4 millimeters for femoral artery. The right one was around 4 point something, and the left one 5.3, I think. Either they are calcified, but I think that we can use it, and we can use both flower, that you can cover the aortic arc, and also the sentinel through radial artery. And the second axis in Vigo, we don't use transcarotid TAVR, we don't do transaxillary TAVR, but we have a huge experience with transcaval. I don't see. I didn't get in the CT how is the distance, but specifically I didn't see the calcified region between the aortic below the lumbar arteries, the renal artery, sorry, and the relationship with the IVC. But if it's feasible, we would for this with transcaval access for sure. We put 2 wires, one of them, if it's possible, in between the leaflets. Otherwise, we between the one disc and the ring, and the probably a stiff wire, let's say Lunderquist, and another one with a balloon expandable valve already set in the ascending aorta for this 21 millimeters and Jude's. I would go with the MyVal 21.5. Thank you.
Thank you, Julio. Just one question here to the audience. Who has had a case that is similar to this one? Can you raise your hand? You should.
What?
Anybody? Nobody had a similar case so far as I understood. Not even you, Didier? Lucky. We are lucky. We are luckier than you. Okay.
So I was presented with a problem, and I tried to solve it. So I did a search, and then I end up looking at these papers, and the first one was done in Berlin in 2000. And they only protect 2 of the arch vessels, which I find it odd, because they didn't protect the left subclavian artery. So, and they did it just with 1 wire. So then I end up reading this paper by Nacho, and I call him back. And I present him this case and ask if this was doable. My point here, what was scaring me the most was the accesses, because the accesses were really lousy. So I had this conversation with the Flower. Flower is an Italian company named Aortic Lab or something, and they have this Flower filter, which is a 12 French filter and covers all the 3 arch vessels. So I asked her, and she sends me this WhatsApp that she thinks that the axes are borderline for a 12 French filter, and I'm supposed to be using a 24 French dry seal. So how can I go ahead with this? And then I exchanged some WhatsApps with Nacho, and again, I'm forcing, this is my point, I'm reviewing the axis and puzzles me. How can we use dry seal 24? And by this time, I was already convinced that we could do the case, putting the valve there, but I was afraid that we'll end up with a big time rupture on the iliac or femoral vessels. So we went ahead. Our setting was bilateral. The best artery was the left common artery. We put the 24 dry seal there with some effort, I must say. And we always do in our lab, as a routine, our second axis is a 4 French on the superficial femoral, because we always have a wire crossing the main axis. So we put on both sides 2 right femoral arteries with the 4 French sheets back up with a wire. It can be a coronary wire like the Grand Slam or the V18, and we put them floating in the descending aorta. With that, we are covering our beds. If we have a big time vascular tragedy, we'll solve it pretty quickly, or so I hoped. So, in the first one, you are seeing the right Judkins. In the second one, you see the arrival of the flower filter. And then on the third one, you are seeing the crossing of the second wire. So we cross the valve with 2 wires, and this changes everything. The case done in Berlin, they only did it with 1 wire. So we bring the 12 balloon in, we dilate it, and then we crack and open up the valve, and we implant the MyValve 21.5. Can you put the films moving, the second and the third, please? The second and the third are not moving. And the second is the most important slide of the presentation. No. Before, please. So, can you put, okay, the second one?
I'm not sure that we can...
The second and the third, which are the most important? Come on, guys. We checked that. You can't? How come? Oh, Jesus. So, okay, so some details that you have to consider. You are not supposed to fast pace because you want everything to go out. In the Berlin case, they protect the right coronary artery, but they did just put 1 wire, meaning they took 2 minutes and 7 seconds between the opening up of the valve with the balloon and putting the TAVI valve there. And then they were on CPR for 70 seconds. Now, if you look at this image, if you go with 2 wires, you open up, you crack the valve with the balloon in 1 wire, and you have the TAVI valve working as quick as possible, put the valve there. I can't believe that the most important slides are not running. So anyway, this is our final result. You see some of the fragments of the discs on there. To this day, we still do not know how we got away with a 24 French dry seal in a less than 6 millimeter calcified vessel. The patient was discharged at the third day, an eventful recovery, well and ambulatory, no further admissions for heart failure. Warfarin switch for NOAC and echocardiogram with normal aortic valvular function. As controversial as it may seem, probably for most of the surgical community, I think that it will take some iteration, but one day I think all the valve involved, or most of the valve involved in mechanicals will be done percutaneously. The flower filter is the unsung hero, is one of the two unsung heroes here. Is a 12 French filter. It covers all the aortic arch branches, and they were very nice to us because the proctor flew in and they gave it for free. It was the first flower filter used in Portugal. There is one reason that you need a large sheath, because as you can see, whenever you crack a mechanical valve, some of the fragments will be big. So you have to have a big funnel, sort to speak, to recapture some of these big chunks of carbon. The second unsung hero is the dry seal. I think the dry seal saved the day. And after 3 months, we are supposed to do a full body CT scan, and we only find a small fragment on the left subclavian territory. But the patient is doing very well without any limb limitations. Just as Julius said, 2 or 3 weeks ago, 3 papers were published about the valve involved in mechanical valves. So one wonders if this is the next wave to catch for us percutaneous valvular interventionalists. So I don't know if this was a one-off or something to be repeated. I'm looking actively for more cases, and the patient is just doing fine. Thank you.
So thank you, Duarte. It was brilliant. I think we all learned. Hopefully we won't have the chance to do the same, but nevertheless, if it happens, we'll call you, of course. But any comments from the panel? I think this is self-explanatory by itself, but anyway.
My first comment is congratulations. You did a very good job, but I usually say that if we have a hammer in your hand, everything seems like a nail. But in this case, you have a very good hammer in your hand. You did it very well. And after I congratulate Ruben, you was very brave to be here with your talk about the limitations of TAVI. And after your talk, you did it in the other way, in the other point, you spread the feasibility of TAVI. I think it will be perhaps the future, but I think this technique, it is not, you could not prevent with this technique in 90% of the cases a good result. So I think that we should, in the next years or next time, to get more information about the technique and to be more quiet about this enthusiasm of this valve in valve.
So congratulations. This is one of these THV Mission Impossible, definitely. I remember more or less 10 years ago at our cath lab, we received from another colleague, cardiologist, exactly a request like this. There was a mechanical valve that it was not functioning properly, so the request was for TAVI. And we just looked to each other and said, this is completely impossible and will never be performed. So this was probably someone that was already very futuristic, because it was still before the first case at all. So I have to congratulate all the team. So one of the things that puzzles me is how come we do not have more pieces of the metallic valve all over the body? Would you care to explain us a little bit how the flow works?
It has kind of 3 layers of filters. It has kind of 3 layers of filters. It covers all the way the arch. You have 3 sizes. You are supposed to have a CT scan, and then the size of
We don't have sound in this mic.
The size of the filter is measured accordingly, and you are allowed to put in a pigtail or another catheter, because the aim of the filter is not valve in mechanical. It's TAVI, regular TAVI. And whenever you put a sentinel, it puzzles me. You are protecting 2/3 of your brain. Now, if you are imploding a valve in my heart, you better be sure that you cover all my 3 arteries. I'm not very bright. So if you put a metal disc in my brain, I won't get better.
Okay. Arif, any comment? Okay, so thanks. Thanks a lot for this brilliant case. So it's my pleasure to call Gabriela Tirado. She's currently working in São Carlos, and I think you've worked with Ole in Copenhagen, isn't it? So it's a pleasure to welcome you in this session. So please move ahead, and then João Silva Marques is going to discuss the case with you.
Yeah, thank you for the invitation. It's a pleasure to be here and presenting these Mission Impossible cases. I don't know if we can have my slides. So I think the previous session about TAVI in TAVI and valve in valve, aortic valve in valve, will help to solve this case. So in summary, this is a 78-year-old woman. She had hypertension and dyslipidemia. She received a SAVR in 2009 with a mitral flow 21 millimeters, and as you know, this valve have the external mounted leaflets. She also had breast cancer 2 years ago, and she was treated with radiotherapy at the chest. So that's an issue for surgery. And she presented to herself with a structural valve degeneration, mainly with aortic regurgitation and also with some increase of transprothetic gradient. At this point, she had moderate LV dysfunction, and she was on NYHA2. When we were assessing this patient for maybe a TAVI, a valve-in-valve procedure, she was admitted due to heart failure with very increased NT-proNP, and I mean the anthropometrics were more or less normal, with normal BMI. And here you can see the TOE of this patient. You can see the LV dysfunction with a very dilated LV, with severe intraprosthetic aortic regurgitation. The coronaries were also assessed without any lesion, but you can see that the takeoff of the coronaries were quite low. And of course, the main issue is to analyze the CT and to assess the size of this valve and the risk of coronary obstruction. So here you can see that this is a small annulus with a perimeter around 62, which is in line with this size of valve. The mitral flow 21 is 17 millimeters through internal diameter. This is a fracturable valve, so at least one good thing. And as we say before, the leaflets are mounted outside of the valve, and this is an increased risk of coronary obstruction. Sorry. So regarding the coronary obstruction risk, you can see that both the right and the left coronaries were below the risk plane, which is 13 millimeters, because that's the height of the valve. The left is in 6.8, and the right is around 8 millimeters. Unfortunately, the VTC and the VT-STJ for the left coronary were quite small. In the VTC was 1.3, and the VT-STJ was 0. So here we have some risk of coronary obstruction in the left coronary. Regarding the right, fortunately, the VTC and the VT-STJ were above the limits we know there is between 4 and 2. So the femoral arteries were good, but also we found that the patient had a thrombus in the left atrial appendage. So this is a summary: 78-year-old woman with a mitral flow degenerated, small valve, and with high risk of obstruction of the left coronary.
So now I called João Silva Marques to discuss the options in this case.
Okay, so it's a pleasure to be here in this session, joint session of APIC and CSC, and to discuss this challenging case by our colleagues. So for the discussion, I just learned that the patient didn't have the right radial access, so some things that I will say will not fit into that, but other than that, we will discuss. So we have a not so young patient, 78 years old, and it's not suitable for reduced surgery, but in the heart team discussion, that should be an option, because certainly we can assess for valve-in-valve TAVI. It's feasible, but we have a high risk of coronary obstruction of the left main. So our main concerns, and my main concerns, would be how to prevent left main coronary obstruction, also how to optimize the valve expansion and how to optimize the gradients in such a small valve, and how to manage the embolic risk, since the patient has a left atrial appendage thrombus. So for the regarding the coronary obstruction risk, we know that we have a high risk because we have a valve to coronary artery dimension that is well below the cutoff of 4, and way below also the cutoff of 2, that puts her into a high risk of coronary obstruction. So we have to do something to protect that left main. We have several options. One of the options that we have is the chimney stenting of the left main. It's I must say that it's the option that we take most of the times in our center, and although I'll discuss other options, this would be a first option in our center up until now, but we are rethinking our workflow in this type of patients. The other option would be the basilica. The patient doesn't have much calcium on the valve. It is a bioprosthesis, and it's well centered and well aligned with the commissures of and the left main is right in the center of the valve. And so this could be also an option to do basilica for the left. Other options would include, as we had in the previous talks, in the previous session, unicorn if we are thinking about a balloon expandable valve, or lamacorn if we are thinking about a self-expandable valve. So regarding the protection, we may have these 3 options. We may have also some overlap, and we may have to use more than one if we are thinking that the risk may be too high. And regarding the device selection, what we know from the Lighten trial is that up to 3 years, the short frame self-expandable the balloon expandable valves, in terms of clinical results, they are not different from the self-expandable valves that are supraannular, but in terms of gradients, we may risk to have high gradients, and in this case, that it's a small valve, it's a 21 millimeter valve with a short area inside of the valve. We may have to think of different strategies to decrease the gradient, and one of the options would be to do valve cracking, which is an option in this case. So the choice could be among several different options. If we go for a self-expandable valve, as we've seen in the previous talks, in the previous section, when we go for a too deep implant, too low implant, we may risk to have higher gradients, and this would not be a good option in this case. And valve cracking would be definitely something we would look for if we are implanting a balloon expandable valve. Regarding the embolic risk, we know that patients with a left atrial appendage thrombus have a high risk of events, not only during the TAVI procedure, which we will not touch the left atrial appendage, but have a high risk of embolization in the year after TAVI, and also a higher stroke risk. So if we had the right radial access, we would consider putting a sentinel. In this case, because it's the only device that we have in our center, if the humeral artery is accessible, we could plan to put it in that location. So putting it all together, my options would be to do the first case in my center of a unicorn plus a balloon expandable valve plus fracture, and probably when doing fracture also to protect the left coronary artery. We have some pros and cons regarding this option. The other option would be to go for Lamacorn, a self-expandable valve that would be done with commissural alignment, and hope that the leaflet would not disrupt into the front of the left coronary, as we have seen in the previous talks. Just a brief introduction to what was said before. In these very complex patients, we may have some tools for simulation, and we have this simulation that we did in a case in which we did in the last APIC meeting for a valve-in-valve case. This was different devices tested in the same anatomy using this type of simulation, and also try to assess how coronaries could be protected by the use of basilica, as we can see in the lower picture on the left. We also did in this meeting, we did a patient-specific simulation using 3D printed simulation and using the real device, the real surgical valve. So these are maybe questions for the future that we may think when we have some very complex patients and we have to plan. We have some tools that we can use. But I'm eager to know how the case evolved.
Okay. Let's have the last episode of this one.
Okay. Well, I think a lot of things have been said about this topic today, so I think you will find our solution right. So I'm not going to go again with the case. Our strategy, we start with anticoagulation for the LAA thrombus. And fortunately, when we reassessed the patient at the procedure, there was no thrombus in the LAA, so that was lucky. And we decided to go with leaflet modification with the Yamakura technique because we want to place a self-expandable device to achieve the better hemodynamic result. And followed by bioprosthetic fracture. So this was the setting. We didn't use the radial access. We were under general anesthesia and guided with the TOE. We used 18 French dry seal sheet through the radial femoral, and we use a left femoral 6 French to protect the left main after the JAMA coronary. Here you can see the projections we use to plan the procedure. So we aim, when we perform the left leaflet, to go to the basal portion of the leaflet and in the center of the leaflet. So here you can see we went with 7 French AL4 guiding catheter using a fine cross and a stato wire, and you can see in the left side of the screen that the direction of the stato wasn't right, so we use a modern child technique with a 5 French JR4 to achieve a better direction of the stato, and we were able to perforate the leaflet. We could see that the wire was in the LVOT, so that's also important because sometimes you can go to the left atrium. So here you can see that we cross the microcatheter, we change the wire, and we start sequential balloon dilatations. We exchange for a 0.035 wire to dilate also with a vascular balloon and with a true dilatation balloon. And with the 20 millimeters true dilatation balloon, we were able to break the leaflet. You can see here in the TOE how the leaflet was completely broke, and the wire was not in the left leaflet, but in the center of the valve. So at this point, as we have seen before, we decided to protect the left main with a JL 3.5 on a wire to have an option in case of the leaflet, the breaked leaflet went to the left main, and we deploy a navitor vision. And we did previously a commissural alignment, the descending aorta, also to achieve a better result. So I'm not gonna bore you with this, with the implant. It was quite slow and stable. And here you can see the result. We did then the valve fracturing with a 20 millimeters true dilatation balloon at 6 atmosphere. And here you can see how the left main is patent. And then we decide to take out the catheter. Here is the final angio with the left main and the right coronary open. And the hemodynamics result with a 12 millimeters mean gradient by TOE and 5 in the hemodynamics assessment. We also re-engage the left main with a JL4, and you can see that the commissures are well aligned and that we can reach the left main. Finally, the evolution was good. In the echo, the mean gradient at the discharge was 4. At 30 days follow-up, the ejection fraction was normal. And we did a post-procedural CT, and you can see this is how the valve is underexpanded, as especially in the inflow portion. Is 70 millimeters according to the internal diameter of the valve, and it's a little bit better expanded at the portion of the leaflet. She also had some degree of halt without hemodynamic impact. And these images are really interesting. As you can see, you don't see any leaflet in the outer portion of the navitor in the leaflet, in the left, in front of the left coronary arteries. But you can see that in the right and the non-coronary sinus, you can see the leaflet of the mitral flow outside of the navitor. So you can see the result of our procedure. So I think that's the management we did with this case. We have to think very through these cases. We have to plan with the CT and have all the info before doing the case. That's all. Thank you.
Congratulations, Gabriela, for this nice demonstration, this case. I have one comment and one question for the panel. The comment is, in general, for fracturing, I personally tend to do fracturing after implanting the valve, as you did. But in these cases of Lamacorn, I've done some cases in which, since you need to predilate with a valvuloplasty balloon, I have done the fracturing in the initial predilatation. You put the valve and then you don't need to post-dilate, since sometimes you might have, if you end somehow shallow with the implant, you avoid post-dilatation. Just a comment. I don't know what is your common practice. And the question for the panel, if in the case that when you did the DEE, the day of the procedure, you had some thrombus in the LAA, would anyone would you have considered doing empirical LAA closure before doing TAVI? Because this is a very high risk procedure for stroke. You will do long pacing, so on. So I don't know. What do you think?
You want the panel to comment?
Yeah, for the panel.
Yeah.
Arif.
I mean, this is a nice case because you can get super nerdy on all the different like EOAs and leaflet coronary protection. To answer your question, first of all, I think it's fine to give anticoagulation, and then if the TOE shows it's completely clear afterwards, it's easy. You can also close the appendage, this no-touch technique, and just put something in and then see.
Was quite proximal.
Proximal. So yeah, maybe I think anticoagulation was safer. One thing that I quite like doing in these scenarios, because it's small surgical valves and you always worry about ppm, you had the height and the weight, you can calculate the body surface area, and then you can look at, I think Rebecca Hahn has published charts which tells you what effective orifice area you will achieve with different self-expanding or balloon expandable valves. Then you can work out what is your risk of patient prosthesis mismatch likely to be, because in these scenarios it says if you fracture you might need a bigger valve. So sometimes what we do is we see that, look, if we put in, let's say, a 23, we're not really going to have ppm, so we're not really going to fracture. And of course it's a mitral flow, the leaflets are on the outside, so you do have a risk of pushing everything even closer. So sometimes you can do the upfront calculation of ppm risk and decide, okay, maybe I can avoid a fracture completely. I think from coronary protection, yeah, you can do anything, and it was nice. It worked, of course. Sometimes I just wonder if the Evolute buys you a little bit of space because of the waist. And so you have a little extra VTA with the Evolute. And of course you can align an Evolute, but yeah, you did it nicely with the Navitor with this descending aorta thing. So yeah, cool case.
Thank you.
One question for you. Balloon fracture, the one that was mentioned before or after the TAVI deployment? What do the not balloon? Yes.
The closure. My comment about this case is following the thoughts of Ruben. The surgeons doesn't think in interventional cardiologists, because if this lady some years before have the enlargement of the aortic root, you don't have this problem. So this is really, as you said, you should plan the procedures, and the surgeons should plan now the TAVI and TAVI. About the closure of the appendage, I think it is. I think you did it very well. I think that it was not so useful to have this in the same procedure, the closure of the appendage.
Gabriel, but you had TOE, and the TOE confirmed the thrombus, because it's very uncommon that the CT scan from TAVI does suggest a thrombus that is not actually there.
There was some doubt about the thrombus that we saw in the first CT, because in the follow TOE after anticoagulation, she didn't have any thrombus, so we thought, well, maybe this is a pectineus muscle or something. But then when I analyzed the post-TAVI CT, it was clearly thrombus. I mean, there was that image that we saw in the CT wasn't, and the LAA was completely full with contrast, not like in the previous CT, in the second CT. So I really think she had thrombus, and it would solve with anticoagulation. Okay. Comparing the two CT scans, the same technique.
One more comment about the surgeons. I don't know if in Madrid is the same, but in Portugal, in these small annulus, many times the surgeon not put the valve really in the annulus, but a little not horizontal. So this is another point that is important for us.
João.
Yeah, in that point, I think that's the reason we had such a small BTC in the left, but a bigger one in the RCC.
For the case, I just have a comment regarding the thrombus. So we are using delayed phases like venous phases for assessing the thrombus in the left atrial appendage, because we have a lot of false positives in that region because of slow flow in the LAA. So I think it should be a different protocol to assess that for CT.
So if no other comments,
Only not one comment. It is, I saw in Madrid some years ago a case of in the same procedure with the closure and the TAVI, and the patient had displacement of the device in the left ventricle, and it was fatal, I think.
Oh,
was.
Really?
Okay. Yeah, Ruben, go ahead.
One small question. I'm curious, why did you choose an intraannular valve in such a small valve, surgical valve? Why didn't you go with a supraannular valve?
Well, that's a very good question. We have done several cases with Navitor in valve procedures, and we have seen that the hemodynamics is quite good. Even if the intraannular position of the leaflet, the hemodynamics you achieve is similar to the self-expandable to the supraannular device. So I think this thing about hemodynamics is mainly because of the self-expandable and not that much about the intraannular or supraannular position. But of course, you could also do this case with Evolut, for example.
And you have large shells also to access the coronaries, as you mentioned, as you showed, because in the end, afterwards, we could cannulate the left main. So, yeah. But anyway, so we have to move on. So, for the sake of time, so I'm going to call Julio Ecarter to present the third case. Let's see what happens in this Netflix series.
Yep,
So
I
it's
will
now
be
it's what? Go
briefly.
ahead.
7 p.m. So we are moving from aortic position to mitral space. So this is a 77 years old male with a history of hypertension, dyslipidemia, BMI around 27. He was in the outpatient clinic due to severe degenerative mitral regurgitation, mild to moderate, reduced ejection fraction. He was in GDMT, and now he presented again to the outpatient clinic due to worsening functional class with a YHA class 2-3, despite a diuretic treatment increase. In the transthoracic echo, nothing new, ejection fraction around 45, severe MR, moderate TR, and normal RV function. In the coronary angiography, significant lesion in the distal AD, but only for medical treatment. Renal function pretty okay, and also the hemoglobin level. So this is the most important slide for this patient. The transthoracic echo, we confirm again that this patient has from mild to moderate reduced ejection fraction. We have this severe primary MR due to this huge prolapse in P2 flail that we can see in both 3D and the explain of the bicommissural view. And usually in Vigo, when we have this type of patient with complex mitral valve disease, we do also CT analysis because we are in so many pivotal trials, but also in order to understand better the etiology. Of course, in this case, was super clear before, but the flake height was around 9, the flake width around 17 millimeters, very complex. And also we look on other measurements, the distance from the papillary muscle to the, in this case, for the anterior mitral leaflet that we can discuss later with the solution of the case, but also different things regarding the papillary, regarding the annulus, etc. So this is why what we put on the table. This patient didn't want to go for open heart surgery. Of course, it's an option we can discuss later with Duarte. The other option would be TMBR, and the most common mitral TR with mitral clip Pascal or other type of devices that we have also in vivo in some pivotal trials or anything else?
Thanks, Julie. Okay. I'm doomed to die. Okay. So how would I treat it? These are my mitral intervention tools. I edge to edge with both MitraClip and Pascal and mitral valve balloon valvuloplasty. And the question here, can I get a good, consistent, and predictable result in these patients with these tools? You cannot or should start a case like this just because in that particular day you feel lucky. So these measurements are quite outside the operating window of the edge-to-edge devices. Should you try it anyway? Consider a 2 or 3 clip approach with, for instance, a MitraClip's XTW. As interventional cardiologists, we are used to push the boundaries, right? So, sorry guys, I cannot do this case because I do not have the right tool and expertise. I do not and I should not rely on a stroke of luck, and possibly I'm just plain dumb. So, as far as you put me here, we are down to a transcatheter mitral valve replacement or to something else, all right? 20 years ago, what do we do? We ask to a surgeon, can you repair or replace it? And probably we would like to have it repaired, right? So how come, Julio, are you not giving me any information about the nemesis of the whole transmitral valve implantation, the LVOT? Where is the LVOT measurement? So you are leading me to your solution, right? Then you can put a mitral prosthesis here, but you can do it better if you fine-tuning to the where the problem is in the valve. So with the information that you have given us so far, I think that we have two options here. Or a mitral prosthesis that does not deal with the LVOT because you didn't give any measurements of the LVOT, which is quite suspicious, all right? So you have to put an alta valve, which is the only valve that does not care about the LVOT, or do just what a good surgeon would do, repairing the valve with some type of corda. And as far as the Google say, there are 3 systems of mitral repair. You have the neocord, which is transapical, so you are anchoring the distal anchor in the apex. You have the harpoon, which is also transapical, and then again you are anchoring the distal anchor in the LVOT. Or you have this device, the CordArt, which is a full cardiologist procedure, transeptal, and you are supposed to anchor the distal anchor not in the LVOT, but on the papillary muscle. So this attention to the distance of the papillary muscle and its thickness was the best things about your choice of the device. So in summary, in this patient, the best, most elegant choice is to put some sort of cordal replacement on the valve. So break it to us, Julie.
Thank you. I completely agree with you. So I didn't show the LVOT measurement for two reasons. The first one, in the first case, you showed me the femoral axis. You didn't show anything else. I'm teasing. And the and the other one, I wanted to put you easier. So as you said, these measurements are completely out of the box. As you said, so we can use TMVR with Alta valve. That we have done cases with DMR in Vigo also. But for this case, in our center, we are very lucky with cardiac surgeon team because we have a patient older than 75, kind of reduced ejection fraction. They trust in us a lot, and we went with Corda. Corda belongs to the Core Medic company. This is a Germany company. Basically, you can see on the right part of the slide that basically has three components. The distal one. That is an anchoring distal that we have to put it in the papillary muscle. This is for nitinol. The cordar, indeed, that you have different measurements that we can discuss later how we do it, and the proximal anchoring in the posterior leaflet that is for nitinol also. It's very important to pay attention that this therapy doesn't burn any bridge. What it means that if this therapy fails, we can move forward with a mitral TEER procedure with their device, mitral or Pascal or Dragonfly or whatever. We can do TMVR procedure with any device also, or either surgery. That in this patient wouldn't be like crazy stuff. So this is a quick video. We go from transeptal puncture. We grasp the posterior leaflet. We deploy the distal anchoring through the needle. We retrieve all the system, and at the end, we deploy the proximal anchoring. In this way, we respect the anatomy, and hopefully, we can solve this kind of complex mitral valve disease. So, this is the first clinical experience in Spain, one of the first in human worldwide, because the first cases were published and were done in 2021 by Alberto Weber from Switzerland. The usual height that we need for cordal replacement with the device is a usual one between 3.5 to 4.5, and we need to be coaxial. Over the prolax, we use a lot the transgastric view with an X-plane in order to assess the papillary muscle and the cordal length, and you can see on the right part of the slide is around 23 millimeters. So that's why we decided 22 millimeter cordal device in order to have kind of tension. The next step would be like the leaflet capture with the grasper. This is kind of difficult. You can see here in the middle of the slide that with different knobs here in the delivery system, what we are trying to grasp is the posterior leaflet, and then we puncture the papillary muscle. The papillary muscle has the, of course, we in the CT previously performed, we decide if it's feasible or not, because we need certain measurements, a certain diameter of the head of the papillary muscle, and after this we retrieve this leaf, and we can deploy both distal and proximal anchoring. As you can see here, in the middle, the video, now it will be deployed the proximal anchoring. So we have distal, we have the cordal here, at the end we have the proximal one. In this patient, we need the second and third cord is the same. The second one was 22, the third one was 20, because we had a good implant. We had a mild to moderate residual MR, but still residual prolapse. And with the 20 millimeters one of cordal device, we got more tension of the leaflets. In this way, we got this result. So the almost no prolapse, nothing from trace MR. On the left, you have the pre-cordal replacement, on the right, post. Amazing result. This is the echo at discharge with the mild mitral regurgitation, and this is 3 months follow-up. So in order to summarize, transcatheter transeptal mitral cordal replacement, is feasible. The implant design and location is crucial for acute and long-term results and durability. Still, we need a lot of information. We need more cases. This belongs to the Chagall pivotal trial. We need much more experience for sure. Multiple cores can be deployed in one procedure. Transcatheter mitral valve replaced with this device has the potential to become a first-line treatment for DMR in patients with suitable anatomy. Thank you.
Very excellent case, and of course this is a novelty. None of us has this experience. How long did it take?
How long?
Yes.
Oh, it varies. We have done five cases. Usually it was the first one. I think that was 78 minutes. This is published now in JACC Kind. I think that was 78 minutes from skin to skin.
Below 2 hours?
Yeah.
Okay.
With 3 cords in this case.
Right.
So probably the part of the procedure that takes longer is the puncture the head of the papillary muscle. But for example, in the last case that we did like 3 weeks ago, I think, the part that it took longer was the grasping of the posterior leaflet. So it depends a lot on imaging. But I think that this is a proof of concept that has been demonstrated with other devices, and with this device also in 2021 in 5 patients. But still, there are still things to improve.
All P2 prolapses, I believe.
All P2 prolapses, yeah. In the Chagall, if you look in the clinicaltrials.com, one of the exclusion criteria is anterior prolapse or whatever. They want P2 prolapse also.
Yeah. Mm-hmm. How does it work? Are you ready cord by cord? Or
so,
you have a set of cords over there, and you implant 1, 2, or 3, or you put 1, you put 2, and you put 3?
yeah, so it's all in the same system. So the delivery system is very bulky with the different knobs. Orange knobs are like a lot of devices. This is the first one of the first generations, the cordal system. But usually it's all in the same system. So we with different knobs, what we do is we grasp the posterior leaflet, we puncture the posterior leaflet, we go to the head of the papillary muscle. We want to be inside the papillary muscle at least 5 millimeters. And with the knob in the counterclockwise, we retrieve the sleeve and it's self-expanded, it's self-deployed, the proximal anchoring. And after, if you need more, we have done cases with 1 cord, 2 cords. The first one, we needed 3 cords. Actually, we had a case that the system failed, as I mentioned. This doesn't burn any bridge because we did like a super quickly mitral tear with 2 Pascal devices, and it's the head of the papillary muscle, yeah.
You only puncture it once, right?
Once. What is difficult is to be there, like to be precise. But it's only once, yeah.
Because we saw it in the picture, it seems like the needle, it's not flexible, so it does not bend. So how difficult it is to orientate it inside the LV to puncture the head of the papillary muscle. Do you have, I don't know, some kind of angulation to let you know? It's just echo-based, turn left, turn right? It's like
this is
you are the pilot and you need someone that is settled at the airport.
No, thank you for the comment. As I mentioned, this is what people from companies says, what Rodrigo Esteveloreiro also thinks. And what we have seen in all these 5 cases is that this is the more difficult part. We use a lot transgastric view. We try to figure it out in the prior CT, how would be the procedure, but still our souls, our minds, it's in Manu Barreiro, that is the chief. For example, in the last case, we spent like kind of time there because the needle was, if this is the head of the papillary muscle, the needle was like, going from the edge, but this was the only case. The previous one was like easier, but I think that the most important for this case is that this is feasible. And this is evolving, not only for this the company. I think that there are more for sure, Neocor, Gore, other kind of companies with so many devices, and this is good for us, I think.
No more comments? Okay, thanks, Julio. Excellent case. Congratulations.
Okay. So last but not least, let's move to the fourth case, another complex case. João, please.
Okay, so we are staying in the mitral space, and I'm presenting the case of a 76-year-old woman that presented with heart failure in class 3 of the New York Heart Association classification, that had one prior hospital admission for heart failure. And this patient had already had a TAVI procedure some years before, in 2020, for severe aortic stenosis with an Evolut Pro 26. And she nowadays has a calcific mitral stenosis that has been evolving in the later years, and now has a gradient of a mean gradient of 11 and an estimated area of 1.1 centimeters square. She has a lot of comorbidities. She's very obese with a BMI of 37. She has paroxysmal atrial fibrillation. She had a stroke already in 2019. She has asthma, chronic kidney disease, and she has a permanent pacemaker that was implanted when she had the TAVI in 2020. This is the echo findings, the transesophageal echo showing the mitral valve with an anatomic area of 1.1 and a mean gradient of 11 in the transesophageal echo. She also had a LVOT gradient that we saw in the transthoracic echo and was confirmed during the transesophageal, that was increased with the Valsalva maneuver up to 56 millimeter of mercury. And there was a trans-TAVI gradient that was a mean gradient of 25. So this patient has an heart failure that had already had an hospital admission. She's at high risk for surgery, mainly based on the comorbidities. So the heart team decision was that she was not eligible for a valve replacement, a surgical valve replacement. And so the decision was to pursue an anatomic assessment for percutaneous treatment of the mitral stenosis. So we did a cardiac CT. That's the main exam that allows us to access the three features that are important to predict the results of a valve in MAC procedure. So we have to assess the anchoring, and we had a MAC score of 8, which is suitable for a low risk of embolization in the mitral MAC. But we had a high risk of LVOT obstruction with a neo-LVOT of 0 millimeters square, so very high risk, and she had already an gradient on the LVOT. So at this time, the questions what we should do next. That's what we are going to hear from Gabriela.
Well, I have to say that when I saw the CD, I say this is really mission impossible. So I'm going to try to say what I will do. So just a summary, this is a 76-year-old female but with several comorbidities. She had a previous TAVI, and she now has severe mitral stenosis with a severe MAC. And she also has a dynamic LVOT obstruction, which means that the possibility of a valve in MAC procedure is at least difficult. And she's a high historical risk and referred for transcatheter mitral intervention. Just to start thinking, I think no transcatheter repair options are possible because, of course, in mitral stenosis, edge-to-edge therapy is not an option. And with severe MAC, balloon valvuloplasty is not usually used because of the calcification. We don't have commissure fusion, so it's not the first option. So just a reminder, mitral MAC is occurs in around 4 to 15% of patients. It's more common in elderly patients and is observed in around 50% of patients undergoing TAVI, so as our patient. This is a hostile anatomy, also for surgery and for transcatheter mitral replacement. We have a rigid and not compliant annulus with irregular geometry, with heterogeneous calcium, and also there is the increased risk of LV obstruction. There have been some scores that as this CT-based MAC score to try to classify the MAC so we can predict the results with transcatheter mitral valve replacement. But in any case, compared with valve-in-valve, valve-in-rig, the valve-in-MAC is the ugly of the picture. I mean, the results showed worse mortality and also less technical success with an increased LV obstruction risk. And this LV obstruction has a really high mortality if it occurs, so we have to really plan this case. So why this LV obstruction occurs, of course, is the anterior leaflet of the mitral valve, which is displaced towards the LVOT. Also, the bulky calcification push the valve towards the LVOT, so that increases the risk of LV obstruction. And this kind of patient usually has a small LV cavity. To predict it, we have to use the CT, we have to assess the neo-LVOT area and also the SCIR neo-LVOT area. And also we can consider the anterior leaflet length and the LV size to assess the risk. So this algorithm seems logic to manage this kind of patient. If we have a small predicted neo-LVOT, we can think in some procedures to approach the ventricular septum and modify that septum to achieve a bigger LVOT, but also we can work in the anterior leaflet with procedures like Lampoon or Batman to obtain an increase of the LVOT. So this is one of our cases with alcohol septal ablation to obtain an increase of the LVOT. As you can see, we achieve a 70 square centimeters of increase with this technique. So in this patient that we have starting in 0, I don't know if we will achieve a neo-LVOT that is going to be big enough. So in this series of 27 patients, you can see that patients starting in the near 0, they don't get enough space to accommodate a valve. But you can start with this procedure and then also maybe things in anterior leaflet modification with Lampoon or Batman. Then you have to decide the valve that you can use in the mitral annulus. There are many devices that has been used in mitral position. We have done cases in MAC with Tendyne device, with M3 Sapien, and also with Alta valve. But most of the experience is with balloon expandable valve in MAC. So I don't know, in this case, what I will do is staged approach. First, do something to modify the septum, probably septal ablation, and then reassess the patient with a CT after between 1 and 3 months. And just in case that we obtain at least a SCIR neo-LVOT above 180, then perform some anterior leaflet modification, and then proceed with a balloon expandable in MAC. But I think the main issue is to obtain at least 118 neo LVOT size after septum modification. So I'm eager to see how you solve this case.
Chapter 3. Thank you.
So we had some previous valve in MEC cases where we did alcohol septal ablation, and in one case we had a very good result, but in this case the patient didn't have much hypertrophy of the septum, so this was not an option that we considered up front, although she had a good septal. So we were discussing this case with Jafar Khan that came to Portugal later last year, and so the plan was pretty ambitious, and the plan was to do a sesame plus a base to tip lampoon to gain as much space as possible. So with the sesame we would get the septum split, and so we would have more area in the LVOT. And with the lampoon, we would take the anterior leaflet out of the way in the LVOT. So we were hoping that with this we could get some space, since the neoskirt LVOT was on the limit of him being an option to do only lampoon, and after that to do a valve in MEC. And when discussing this with Jafar, he never did this in one time, and we were planning to do this all together. So we started the case. This was the team. We had to plan with the CT where we would go with the wire inside of the septum to split the septum with the sesame. And we were aiming at for half of the septum thickness, that was 10 millimeters. So we were aiming for 5 millimeters inside of the septum to do the sesame. So these are images from the procedure. We did an echo-guided access with a left femoral artery, right femoral artery, and two right femoral veins, since we were planning to do also the lampoon. We used the mother and child system for approaching the interventricular septum. We used an Agilis, a large sheet, and then inside of the Agilis we used a 7 French XP3 guiding catheter, then a guide liner, 7 French, and inside the guide liner we had a fine cross with an Astato 40. That's a very stiff wire that we use to penetrate the septum. So we did it based on this pre-planning with the CT, and then we used transesophageal echo, and we had to change positions of the C-arm since we don't have the biplane angio system. And with that, we punctured the septum, we progressed with the wire, and we checked with the transesophageal echo where we were. Then after we penetrated the septum and we had a good position assessed on the transesophageal echo, that was really difficult to see because this patient had a MEC, she already had a TAVI, and she had also the pacemaker leads, so it turned to be really difficult to see the microcatheter inside of the septum. We snared inside of the ventricle with the end snare at the apex. We make sure that we didn't entrap any of the mitral chorda, and then we did the laceration after creation of the flying V that we have here. So we put it 70 watts and we pulled the system in creating the sesame and splitting the septum apart. And we had a very high gradient at the beginning of the procedure that was almost 100 millimeters of mercury. We managed to get some reduction on that LVOT obstruction. and then we moved on to the transeptal, moving for the lampoon. So we did the transeptal, we did the septostomy with the 14 balloons, we replaced 2 agilis, and placed the hand snare on the apex of the LV. But when we were preparing to do the lampoon, and after we put it in an intra-aortic balloon pump, we saw that the blood pressure was coming down after we did the septostomy, so probably we didn't feel that it was too safe to do the lampoon and implant the valve for the valve in back. So at this time, we stopped lampoon, we checked the gradients on the LVOT that were pretty high also at that time, and we decided to repeat the sesame because of the challenges that we had with the transesophageal echo. We couldn't be sure that we had a good depth inside of the septum. So we came again for the left, sorry. So we came again for the left and did the sesame once more, and we decided to stop and reassess the patients with a CT scan sometime after the procedure. So the patient was discharged on day 1 after the procedure. The LVOT gradient at that time was 85 millimeter after 2 repeated sesame procedures. And I think Jafar Khan told us it was the first time that he did 2 times. And the patient kept the same symptoms and was re-evaluated in the outpatient clinic. 2 months later, the echo showed a very good regression on the LVOT gradient to about 15 millimeters of mercury. So the effect of the sesame most of the times is not immediate, and it needs some ventricular remodeling. And so we repeated the CT scan, and it showed again a good anchoring, probably a low risk of embolization, but still a very high risk of LVOT obstruction. So at this time, we had gathered some experience from previous cases of doing a valvuloplasty using shockwave balloons in the mitral. And so we decided that for this patient, probably it would be a better option to decrease the risk of having LVOT obstruction, to go on and do the valvuloplasty with 2 shockwave balloons in parallel. So we use a technique that is with 2 12 millimeters peripheral balloons that are inflated simultaneously. We usually, in the previous cases, this is the 4th case that we do. In the other cases, we didn't have to do rapid pacing, fast pacing. But in this case, the balloons were tending to come out because it's a very small left ventricular cavity. And so we did fast pacing, and we delivered 600 pulses to the mitral. We didn't have significant mitral regurgitation at the end of the procedure, and we decreased the transmitral invasive gradient from 12 to 5 millimeters of mercury. So we don't have much follow-up because this was last week, but I think that this case illustrates that sometimes we have to think a little bit out of the box when we have very complex cases and we have symptomatic patients. Sometimes we have to rethink what we are planning to do as we face new challenges along the way, and that what I would like to point out is that we have some tools that we have to think about, and we are gathering more information about the shockwave balloon in the mitral space, in the MAC procedures. There's a small series of 7 patients in the US in the last year, and some other small series that show, at least for now, some promising results. Thank you.
Congratulations, Joao, for this impossible case. Probably, no, it's okay. I mean, you probably did more than much of, no, more. A lot of us would have done probably, because the initial CD was really disappointing. So congratulations, because you did a great job. I don't know if we are out of time. I don't know if someone in the panel wants to comment something in this case, if would have proposed something different.
No, I mean, wow, what a case to end on. That's amazing. No, it's more about the sesame thing. I'm curious about this procedure, and also if other people have experience. We're about to do our first one in a couple of weeks, so may I ask you some questions about it. But I know the guys in Karolinska in Sweden, they're starting a randomized trial. It's going through ethical approval right now, taking patients with hypertrophic cardiomyopathy and LVOT obstruction, randomizing to alcohol septal ablation versus sesame. Because they've said they've done some cases in HOCM, so not for TMVR, LVOT, but just purely HOCM, and the patient comes in with gradient, let's say 120, you do the sesame, and the next day it's like night and day. The patient feels amazing and completely different. There are no symptoms, and the gradients are down to single digit. So, I mean, it sounds amazing as a procedure. We don't think of HOCM patients because we don't meet them in our cath labs, but I just wonder, is sesame this new thing for HOCM, and I don't know if anybody has experience, but when I hear what they say in Karolinska, I think they've done 7 now, and now they're doing a randomized trial. It seems like a game changer, potentially.
Yeah, I think that in terms of predicting the result, it's much more predictable than the septal ablation, but alcoholic septal ablation, but it's a challenging procedure, and we are still learning. This was the first case that we did, and it took a lot of hours, so I will not tell you.
Not 78 minutes. I'm a little bit biased because I was involved in the procedure and the choices that we make for the patient. So the only thing that I would like you to tell us is regarding the other patients that you did the parallel IVL of the mitral valve. What were the results for long or mid-term
for the
follow-up?
Other patients?
Yeah, for the other patients.
So we started doing it August last year. So we had done 4 cases. These are patients that did not have any other option, and we didn't see any increase in mitral regurgitation. That was one of the limitations of doing balloon valvuloplasty in these cases. So we think it's promising. The decrease in the transmitral gradients are we see about 5 millimeters of mercury. So it's not huge, but most of the times it's enough to improve symptoms. So we had patients that were hospitalized for a long time and that got discharged out of the hospital. And we have one patient that was, it's a very young patient, about 50-something years old, that has had a lymphoma, has had radiation, and has a porcelain aorta. And she had a very good improvement after this procedure. So I think it's promising alternative.
And just probably a provocative, a little bit provocative questions. Do you think that we should start and like in a trial thing, like using medication that are starting to be used for myocardial hypertrophy, like mavacantem, that reduces the masses? It's obviously something that takes some time, but considering the small ventricles and small LVOTs.
Yeah, that's something I thought about when starting thinking about these patients, but we are not allowed to use them, so we don't know. And I don't know if there is any time going to be a clinical trial on that, but it would be nice to have other options.
I always say congratulations, but I think that this technique of double valvuloplasty with shock waves could be very interesting. We have a lot of patients, as you said, of TAVI with his MAX and with his stenosis. So I think this could be, in my opinion, but I'm old, I think much more feasible than the sesame and the okay? Thank you.
Yeah, but even Sesame, when we were discussing the case with Jafar Khan, he told us that he had a lot of patients that were going for Sesame before valve MAC, and then they got better and they didn't need the valve MAC procedure. So,
as you said, A little drop of the pressure is enough to get a good clinical result. So I think you should. But I think it is. Have you some registry or something about this?
We are collecting our data, but we are not participating in, at least for now, in the registry. But we would like to have more centers involved.
Well, if there is no more questions, thank you to the presenters for these amazing cases. I think we all learned a lot. Thank you to the panel and to all of us for staying until late. I think it's time for dinner. No? Thank you.